Good morning. So we'll start off the Venus session in the SETS program. Dr. Nalaga Gunawasha is running a bit late, so until he comes, we will start the program. So for the first presentation, I invite Prof. Qasim to start off with clinical assessment of varicose veins. Thanks.
One person, one of you have to sit there as a moderator and asking questions. Right. Good morning, everybody. I've been given, how many minutes do I have? At least 10 minutes. 10 minutes. Okay. The next 10 minutes, we need to do a clinical assessment of varicose veins. Clinical assessment means history and examination both, right? So you can ask for heaviness. Some are very specific, some are very non-specific. Sometimes they can't even tell exactly what's wrong. They say the leg is different. Heaviness, tired legs, desire to sit. They can't work as long as before, right? Itching of the skin, night cramps, throbbing pain or this thing, burning pain, which is more neuropathic. Sometimes when they come and tell you, think that they have neuropathy, but it's just because they have something that they can't describe. So they use various things. Aching of legs, which is exacerbated when in the erect position or seated position. And when they walk a lot, they have pain. How is it? Now, this acute complication, the second thing is wrong. You never get deep vein thrombosis due to varicose veins. Understand? You can get superficial thrombophlebitis. So just ignore that part of it. So acute complications of varicose veins, you should ask for a history of superficial thrombophlebitis, bleeding. Those are the acute ones that we are worried about. However, having said that, this should have come in a different slide. One of the causes of secondary varicose veins are deep vein thrombosis. Right? I'm going fast because all of you know this is undergraduate stuff, assessment. And there is activity limitation and past history of trauma, DVT. Another thing that pregnancy has precipitated it. So in inspection, you may see reticular veins like this, right? Then slightly bigger ones, spider veins, and then you have the smaller fellows, reticular veins. So sometimes it's a cosmetic issue for these people. Then you have the formal varicose veins where the skin has come out. The vein is lifting the skin up. So when you inspect, you must look at all these and the distribution. Now, this is the distribution of the short saphenous vein system, not the long saphenous vein. Then you can have, this slide doesn't give justice to it, eczema, itch. What starts as a itch, then it becomes eczematous, then it goes on. Then there is hyperpigmentation, and this person, apart from hyperpigmentation, also has an ulcer. So that that area just above the medial malleolus and the lateral malleolus starts getting darker and darker. It starts with spots. Then they all coalesce and become an area. And the shape, when you have lipodermatosclerosis and all, the shape of the leg becomes like this. So you must look for this type of shape. When you see a patient and you're assessing, see whether, now when you start seeing skin changes and shape changes, you know there's significant venous hypertension, right? So if there is no skin changes, no shape changes, just symptoms, they have venous hypertension, but not causing physical problems. But still you need to deal with the symptoms. This area can get depigmented and sclerosed. And some of them even have a saphina varix, the top end, which is refluxing the SF junction due to the prolonged standing and reflux each time they cough or strain. That area gets dilated. Can you see that lung? So now, even if it's not dilated, if there's significant reflux about 4 centimeters lateral and below the pubic tubercle, you should be able to keep the hand and tell the patient to cough, look away and cough, and the cough impulse will be positive. So you don't need a duplex scan to say. Now, unfortunately, to tell the truth is, now because of all our, anyway, I'll tell it at the end. So that lump is soft, compressible. It looks like a hernia. When you make the patient lie down, it disappears immediately, whereas a femoral hernia won't disappear. And it shows expansile cough impulse. And there's a thrill also. A hernia won't give you a thrill, only a cough impulse. So sometimes varicose vein may be part of another syndrome, like Klippel Tenoni syndrome, or part of AVM, where the lymphatic and the arterial components are not so visible. Then you see only the varicose part of it. But then you look for varicose veins with limb hypertrophy, then various skin lesions, which is pigmented, that looks like capillary. And then also, we all know the distribution of the long saphenous vein and the short saphenous vein. When you start seeing abnormal distribution of varicose veins in the lateral side of the thigh, in the buttock, then you know we are dealing with something else. Very, very rarely, which are not touched in females through the ovarian vein reflux, you can have vulval varicose veins, which again, if neglected and they don't tell anybody, it can go right down to the leg and you'll have long saphenous vein communicating and you have varicose veins in the leg. But there is no axial to deep vein reflux in the leg or the lower limb. It is coming from the pelvis. So when you're scanning, you have to look at all these things. And this is a picture of a hypertrophied leg. Now, when you palpate, you look for pulsation and the fluid thrill when you cough. Then when you feel along this thing, you can feel fascial defects. But in this day and age, it is not very relevant because you have duplex scans which catch it all. But always, even though we are discussing varicose veins, you must always check for peripheral pulses. Why that is part of the treatment of all this is compression therapy. So you can't compress a patient if the ABPI is less than 0.7. Okay. So, but as far as you're concerned, say if the pulse is not there, I won't compress. It doesn't matter. But up to 0.7, you can actually use compression therapy up to 40 millimeter Hg. And if it is 1, you can go up to 60 millimeter Hg, the compression, right? So those are the recommended levels of compression. So, but our crepe bandage and our stockings never deliver such things, so we don't have to worry much. But if you really have the goods and you're putting 3-layer stocking compression, the target to achieve 40 millimeter Hg, then you must make sure the pulses are there. Okay. Now, then another thing is we need to do the tap test. So let's say there is a long reflux. Now with not long, you have lots of varicose veins that are appearing in different parts of your thigh. Something here, then you say have something visible here. So you need to figure out whether this is the same axial vein refluxing. So what you do is first you confirm they are talking of the same system, because all veins transmit a tap sign upwards, even normal people, because the valves are open. So you percuss down and you feel at the uppermost point where you can see whether they are communicating. So you establish this is one system. Why you have to do the orthograde way first is sometimes you may have, there may be two systems. This vein is draining somewhere else and this is a different vein system. Both are varicose. So if it is not, when you percuss down, you can't feel it up, that means it's two different systems, or there is an intervening clot in between. So history of superior thrombophlebitis is not communicating. You see, so once you establish these are the same system, then you percuss up and then you feel for it down. Then you know that it is refluxing. So every 15 centimeters, there is a valve in the leg, the rule of the thumb. So if you can keep it well apart and you're feeling it, that means there is definite reflux, there is valvular incompetence of this thing. Then the next, why isn't it going? My slides are not advancing. Right. So then we have our, once you do your clinical assessment, all of you know the CAP classification, where C0 is no clinical signs. Then you have the C1 small varicose veins. Then the C2 is large varicose vein. Sorry, the C1 is small, C2 is large, when edema, mild edema at the end of the day comes, that is C4. Skin changes is sorry. What am I can't see. Skin changes without ulceration is 4. Healed ulcer is 5. Active ulcer is 6. So they grade it. And depending on the etiology, anatomy, and pathology, you can all read this. But generally, we just talk of only the C when you decide to treat. So C4 and above, you have to treat. If not, it's going to get worse. That's the take-home message, right? Now, I did it very fast. Now, the problem comes for a vascular surgeon. Now, in real life, we don't do all these things. Then why do we need to learn to examine these patients like this? And another test that we used to do in the past, which we don't do now a lot, is the tourniquet test, which is not here, the Trendelenburg tourniquet test. So it's the same thing. You raise the leg up. Here we are trying to figure out which segment is refluxing. So if you empty the leg, tie a tourniquet at the proximal end, okay, and then put it down and let it reflux down. And if it's filling from the bottom, you know it's coming fast. Anyway, it's going to fill from the bottom. But if it fills fast, that means the problem is in some perforator in the thigh. But when it doesn't come, you remove this, it just fills very fast, then it's there. So segment by segment, you can check with the number of tourniquets. So you can read it off all the book, and we don't do that much now because we have access to what? Duplex scan. So that is our second. Let's say in a situation you don't have duplex scans, you're working in a center and you want to refer to somebody or start therapy or ask for a duplex which is far away, then you can do the simple test to see whether these are there. So that's it's a very straightforward thing. Main thing you need to see when you're assessing a patient with varicose veins is whether there are skin changes like eczema, lipodermatosclerosis, and ulcers, and the distribution of the veins and the pulses. You need to figure that out, whether this person needs treatment or not. And some of these ulcers may coexist with arterial disease. So then you must also check for pulses. Okay, the next one.
So do you have any questions regarding this presentation? So from an exam point of view, are they expected to do the tourniquet test if they
unless asked, they won't. Because now when you go for an exam, you just have how many minutes? 7.5 minutes for a varicose veins case. You get the varicose veins case. So they won't examine the varicose veins. Now they'll say, what do you think? Now you're in the vascular bay, right? So, and you know this is not an orthopedic problem because the person is standing. So it has to be vascular because those two go together. So you must use a common sense also. And you show a patient with pigmentation or an ulcer, and you ask them, what do you think the etiology is? Those are the type of questions you ask anybody who had done the exam. Has anybody here done the exam? No. Yes. And repeated no. So you just ask them what was asked. It's very simple questions that you ask. Definitely in the vascular bay, you're going to have a varicose veins patient. Depending on how the drug go, you may or may not get it. But 50 to 60% chance you're going to get a varicose vein. They are not going to tell you here, examine then tell me where. Then what they will want you to know is now some questions we ask is now there is lots of varicose veins in the leg in 2 different places. I just ask a question. Do you think it's connected? You understand? Are these 2 systems connected? And some candidates can't figure out how to know whether this is connected. Because you have varicose veins here and you have varicose veins here. How do you know whether these are connected? You just have to do the tap sign and see in the retrograde fashion whether it's connected. Orthograde, anyway, they are connected. You understand? So, and you can prove its reflux into that point. And then you say you don't have a duplex scan, then what are the principles of a tourniquet test? Or just show whether this thing reflux or whether there is SFI. They'll give a very focused thing. Do you suspect saphenofemoral incompetence in this young man? How will you prove that? Then you get the patient to stand up. Now, and then see whether there's a saphena varix. When there's a saphena varix, you don't even have to touch to tell that there's reflux there. If not, you can never get a saphena varix in a non-refluxing person. You see. But let's say it's not there, then you can tell, but to confirm, you can tell to cough. So they will just give, and then they start, these are just very easy cases. There is no, so all you have to do, say this is probably due to varicose veins, if you can't see varicose veins. You understand? Now, sometimes you have all pigmentation, eczemas and everything, but no visible varicose veins, but it looks venous to you, not arterial, not lymphatic. So then you say, probably this is varicose venous in origin. If you can see varicose veins, tell this is venous in origin. So this is common sense. Now you have two sets of patients. Now you see one person with varicose veins with signs, another person with signs, no varicose veins. So you say these are the signs. They are all suggestive of venous disease. So the trunk is refluxing, but it has not still had time to become varicose, because then you tell, how will you know there is, then you will be testing the whether there is SF incompetence in a person who in non-visible even you can feel that rate. If it's visible, you can do the tap sign and prove that there is refluxing. And if you, nobody will ask you to tell me which perforate is refluxing, but if somebody is, some examiners come and ask you, tell me whether this perforate is incompetent, all you have to do is put it just below the perforator where you think there is a tourniquet after emptying the patient, emptying the leg, and you make the patient stand up. If it's feeling very slowly from bottom, if it feels very fast from bottom, then it can't be this. It's something from below coming up. If it's anyway, it's going to come slowly. You remove this tourniquet, immediately it comes, then you know there is a perforator. But then they'll ask you a question to figure, how do you know? Now you are tied it in the mid-thigh. How do you know it's not coming from the SF junction? Then you say you don't know. It is something from above this tourniquet that is refluxing. If you want to exclude the SF junction, you need two tourniquets. You first tie just below the SF junction. So now you know that is not coming. Then you have a segment which is free where you isolated your perforator and then remove the bottom one. Then if it's coming, it's a perforator. You understand? You need to explain your physical signs, but it's very, very rarely done. Now I have once or twice I have given in the last 5 years. So it's very rare for us to do that. But we just ask very, 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 very simple questions. Now, for example, I have given candidates and said, I want to make it easy. Now, I'm telling a real life situation. I once went and I said, this patient has varicose veins on the right side. He had an ulcer, now it has healed. And really, I can tell you how things can go horribly wrong in exams. This has healed. A laser ablation had been done. Now, this time he comes with a similar ulcer on the other side. What do you think the etiology is? Now, it can't get easier than that, no? So immediately the candidate goes and puts the patient on the bed and examines and says he has no varicose veins. Then I say, okay, fine, you get the patient to stand up. When he stood up, all the varicose veins came up. Then, so you need to know the technique of, if you want to assess for varicose veins, it should be standing. Now, you can't teach all that here. Any simple book, MacLeod, not MacLeod, Norman and Browse, or he'll teach you simple things. Get your basics right. All you need to know to say this is probably venous or varicose veins. If you can't see varicose veins, you say this is probably venous in origin. It may be DVT, it may be superficial reflux inside. We don't know. You need a scan. You understand when I say venous? All DVT also can cause all these symptoms. Okay? If you can see varicose veins, you say probably due to varicose veins. Then the next thing is, in the clinical evaluation, you must show that you're trying to find a etiology. Have you had deep vein thrombus in the past, pregnancies in the past? You're taking hormone tablets. So then the candidate realizes that this person is trying to get at a etiology. So basically, what is this? What caused this? What is this causing? So what is this? This is venous. What is this causing? You're trying to figure out whether there is history of DVT, OCPs, family history. You understand? Keep it very simple. Then you go for the complications. Do you have pain? Do you have eczema? Have you had ulcers that are healed? So once you have that in the history, that will take even less than 1 minute because you have 7.5 minutes. You have about 6 minutes to examine and discuss the case. Then you say, I can, whatever you see in the leg, you tell. And then examine for pulses, examine for cough impulse. And you ask the examiner, do you want me to do the tourniquet test? They may say yes, they may say no. But they won't let you go, they will, the default in any exam in the world is to try to pass you, to see what you know, not to see what you don't know. But so don't make errors of principle, then you fail. If you get the method wrong, even if your principle is right, the chance of failing becomes extremely remote. Any other, does it help? I don't know.
So then we'll move to the next one.
Yeah, please.
Right. Good morning. So I'm going to talk very briefly about management of truncal venous reflux. All right. So this is the overview of my talk. And what do you understand by the term truncal reflux? So as Sir said, you can get varicose veins or else the chronic venous disease secondary to venous reflux. So that could be due to a reflux of the truncal veins or else reflux of the perforators. Okay. So I'm sure you are very familiar with the anatomy of the venous system of the leg. So I'm not going to touch that. So the truncal venous system comprises of great saphenous and short saphenous vein. And sometimes you can have accessory great or short saphenous veins causing reflux. So if the reflux, the diameter of the truncal vein is more than 3, with the reflux on duplex more than 0.5 seconds, we consider it as a refluxing vein. Okay. So the indication to treat truncal reflux is, as I said, if the patient is symptomatic, you know what are the symptoms they talk about. Complicated means skin changes, ulcers, history of bleeding, or sometimes due to cosmetic reasons. Patients don't have any symptoms or any complications, but they have cosmetic worry. So that is an indication for treatment. So here I'm going to talk about ablation techniques because ablation techniques have more or less replaced the open surgical technique in the treatment of varicose veins due to obvious reasons. Because you don't have to admit for these techniques, no anesthesia, no cuts. So therefore, the surgery has lost its popularity, but it's not completely gone away. Sometimes we have to do surgery in certain cases. So ablation techniques, 2 types, thermal and non-thermal. Thermal means you generate heat inside the vein, whereas in non-thermal, you don't. So there are a lot of thermal ablation techniques, which have been practiced all around the world. But here we mainly do the first one, EVLT, endovenous laser treatment. Apart from that, there's RFA technique, endovenous steam ablation, microwave ablation, HIFU, which is the high intensity focused ultrasound, generating heat. The non-thermal techniques, the foam sclerotherapy, I'm sure you all have seen that being done, and cyanoacrylate glue ablation and mechanochemical ablation. Out of all these techniques, I'm going to describe more about EVLT and foam, because that's what we do and that's what you'll see. So EVLT has been started about 25 years ago. So the principle being, so they use laser to generate heat. If you are interested, you can read about physics of EVLT at home. There's no time to describe all this. All right, which causes irreversible damage to the venous wall with fibrosis thereafter. All right. So the procedure, I'm sure you must have seen this if you have done vascular appointments. So the procedure of the laser technique. So we position the patient in the reverse Trendelenburg position first to pull the vein for us to cannulate it easily. Then you have to make the decision on where you puncture the vein. So it should be the lowest either the lowest refluxing point of the vein, which should be above the hand's breadth level from the knee joint, because we don't do laser ablation below hand's breadth from the knee joint because of the risk of nerve damage. Okay. Then we put a guide wire and then a sheath, and then we infiltrate anesthesia around the vein, which is tumescent anesthesia, which has three functions. One thing is it anesthetizes. The second one is it compresses the vein. Third one is it minimizes the heat damage of the surrounding tissues. All right. Then we do the laser ablation, put compression immediately after the procedure, and we selectively give a post of prophylactic anticoagulants, which is 1 dose of enoxaparin for selected patients. And this is the procedure. And I talked about tumescent anesthesia. It comprises of three things mainly: cool normal saline with lignocaine, which is the anesthetist, adrenaline, and sodium bicarbonate. All right. Right. Aftercare, very important. So you have to mobilize the patient early, right? You have to mobilize the patient early and encourage the patient back to work as soon as possible, which is one of the objectives of the treatment. And we review the patient in few days' time to see everything is all right. At that point, sometimes patient might complain of some petechiae, small hematomas, mild swelling, pain, but all these are self-limiting. So we have to reassure the patient and put them on compression for at least for another 4 weeks. All right. So results. So this is the most important slide of about EVLT, which is non-inferior to surgery in terms of efficacy, which has been shown in a lot of studies. So the success rate of EVLT after 1 year, about 90 to 95% occlusion rates I'm talking about, which is comparable to surgery. And after 5 years, it is about 88. And it's more or less comparable with the surgery, and obviously better than foam injections. And the important thing is, with the same efficacy, they will deliver you the luxury of earlier return to work. All right. With obviously less morbidities, no cuts, no risk of wound infection, etc. And it's a safe procedure because we also do a lot of lasers in daily basis. The major complications are rare. So one of the problematic complication the patients can get is DVT. We call it E-hit. The risk is less than 1%. Okay. So other complications, as I told you, are self-limiting. Okay. Obviously, the quality of life scores are better with EVLT. Okay. So these are the other techniques. RFA, we don't do, I mean, have you all done? No, we don't do in Sri Lanka, but in the UK they do. So occlusion rates are similar and the thermal complications are also similar. DVT incidence, according to certain studies, lesser than laser. RFA you can do in two techniques. One thing is a segmental RFA. You do ablation in segments, or otherwise you can do it as the previous technique. So all the other techniques are still in the experimental level. There is no good evidence for us to replace laser with them. Okay. So is EVLT for everyone? Not really. Sometimes you can't do laser treatment in patients with certain anatomy of the veins. For example, if the venous diameter is very large, more than 2 centimeters close to the junction, it is not that effective. Some people still do, but I would rather do open surgery. If the vein is too tortuous, you cannot advance the laser fiber. Okay, so you have to either do surgery, the stab avulsions, or foam injection. If the vein is very close to the skin, which is not separable from the skin by giving tumescent, then there's a risk of heating the skin. Okay, and below the handbreadth, as I told you, because of the risk of nerve damage, we don't do ablation. Non-thermal ablation, few words about foam sclerotherapy. You all know what it is. It's a chemical endovenous ablation by injecting a sclerosing agent into a vein. Out of the two, we usually use STD, sodium tetrahedral sulfate, 3%. So it is, when you make it a foam, it is effective than using the liquid. because it covers a large area and foam bubbles sort of touch the venous wall more, and you have to use low volume of sclerotic agent when you make it a foam. All right. So you have to do it always under ultrasound guidance. Earlier, the people used to do it without ultrasound guidance. Then you can have a lot of complications, STD, extravasation, intraarterial injections, etc. Okay. Efficacy wise, if you use it as a primary treatment, obviously is less. Okay. But there are indications you use foam sclerotherapy as the primary treatment. For example, if the patient only has the below knee disease, or else the venous trunk is too tortuous with a small diameter, or else elderly people with a limited life expectancy. Okay. And also the treatment of superficial veins. My colleague will talk about it, spider and reticular veins. You can use foam sclerotherapy as the primary treatment. Okay. So these are the frequent complications patient will talk about, but most of them are self-limiting, and it's a relatively safe procedure because it has been done for so many years. DVT, very rare. You can get if you use very large volumes of STD. Okay. Right. Other techniques, cyanoacrylate glue ablation, which is a catheter-directed technique where you inject a gel, a glue, and put pressure. Okay. So still, evidence-wise, it has a non-inferior efficacy compared to ablation techniques, but it has a higher recanalization rate with time when we use it for larger diameter veins. Okay. And MOCA is a dual injury technique where you mechanically disrupt the vein wall with the catheter wire, and at the same time you inject a sclerosing agent. Okay. So this is the important technique, most important slide of my lecture or the talk. So which technique to use? A patient will come with varicose veins where you need to treat, and what is the technique you are going to use? So it has to be a tailor-made decision depending on patient's venous anatomy. Okay, where the reflux is, what the veins, the diameter of the vein, what is the shape of the vein, how close that to the skin, and also the efficacy and safety of the modalities which are there, and patient's preference, of course, availability of technique, and the clinician's expertise. But in our setup, we prefer to do EVLT because it's cost effective and it has shown to be effective and safe in long-term studies. It has a result for more than 5 years. Okay. And if the patient has below knee disease, so we can use either ST foam or multiple step avulsion depending on the diameter at the same time, or else as a stage procedure later. That is clinician's preference. Okay. Right. So few words about the place of SFL. I told you we don't do it usually, but sometimes if the vein diameter is too large, you'll have to sometimes do SFL because otherwise the recurrence rate will be high if we do EVLT. Okay. Right. In summary, proper venous mapping is very important. You have to do, the person who does the procedure should do the venous mapping, not by anyone else. Okay. The vascular surgeon should do it before the treatment. Okay. And ablation techniques are well established and almost replace open surgery. ST form is not for everyone. Wherever you see a varicose vein, you should not go and inject ST form. It's not going to work. Okay. So reassurance about common minor side effects, which are self-limiting. And newer techniques, I told you, are still need further evidence before we replace the existing techniques. So these are my reference. Thank you.
Any questions?
Yeah. Yeah. But the diameter is too large, more than 50 millimeters. I don't think the infection is going to occur very fast. Other thing is the patient will have infection, so it's work. Sorry. Yeah. Then the patient will come with a large the heart swelling there. So they will not like it. That is my practice. Any idea? So what would you do? So they're asking about below knee disease.
Yes.
Below knee disease, so we don't do laser below the hand's breadth.
Yeah.
So when there's a large varicosities below that level,
Yeah.
would you do MSA or foam?
Either. The problem with this large varicosity is when you do, both can be done. And chance of nerve injury is very remote if you stab it vertically. And even if it gets injured, it recovers because you are not transecting, just touching. So neuropraxia. The problem with the foam is you can that cause the problem. You have a huge clot and then start getting pain and sometimes the road disappear, you get them back in about 3 days.
Exactly. Yeah.
You aspirate the clot when it liquefies. The answer to short time from answer question is you can actually do it, but it has its advantages and disadvantages. So people who are used to this, do this, they have no problems. People who have do this, they do no problems. You see, it's just like you're comfortable with.
Have you answered your question? Thanks.
So when you say the vein is too close to the skin, you can't do thermal ablation. Do you have a practical guideline how close it should be or how fast it should be from the skin?
So what guideline says it is less than 0.5 millimeters. The distance less than 0.5 millimeters. But in our practice, actually, so what we do is we try to separate it from the skin and push it down using a tumescent. But sometimes you can't because it's adhered to the skin. Okay, so then it's kind of inseparable from the skin with tumescent. So in that kind of a situation, you can't do laser. Options are there. Still under local anesthesia, you can strip it. So whatever the venous segment proximally, which is safe to ablate, you can ablate. And the rest, under local anesthesia, you can strip, the stripping. Also, if it is too, and the diameter is less than 6, you can even give foam. So according to the guidelines, the distance is less than 0.5 millimeter.
So is there a difference in approaching the great saphenous versus the short saphenous?
Yes, great saphenous versus short saphenous. So when it comes to short saphenous, according to evidence, the laser tech, the EVLT from mid-calf upwards, it has shown higher occlusion rates compared to surgery. So the gold standard would be EVLT. But in great saphenous, it is more or less the results are similar. Okay, but because of the less morbidity and complications, we prefer EVLT. So that is the difference. But in my practice, I do EVLT as the treatment of choice for both ways.
So if only surgery was available for a patient with short saphenous reflux with the saphenopopliteal incompetency, do you just ligate the junction or do you have to combine it with stripping, same as for the great saphenous?
Depending on the case, you can strip. You can strip up to about I think about mid-calf level. You can strip the vein up to about down to about mid-calf level.
So the concern there is you can damage the sural.
Yeah, but the sural damage risk is higher beyond that point.
Any more questions with regard to that presentation?
We can answer the questions later if you want.
So I'll hand over the podium to Nalaka Gunawasha, sir.
Next talk, Malak.
Yes.
Yeah, I would like to invite Dr. Malak Amar Singh to deliver the next talk.
Good morning, everybody. I'm going to talk about the non-truncal reflux disease and the perforators. So as Sajid discussed, you know the truncal veins now. What are non-truncal veins? So anything other than the long saphenous or short saphenous vein and their tributaries as called as non-truncal veins. So that includes perforators and the clinical signs like the spider veins and reticular veins. So these, what's the pathophysiologies of the varicose veins, you all know. Valvular damage and venous hypertension causes the dilatation and tortuous veins in the leg. The perforator incompetence is doing the same thing. As usually, the blood is flowing from superficial to deep, but when the valve in the perforator is incompetent, when the the muscles pump in the deep veins, the blood can come back to superficial veins and they can dilate and end up in reflux disease. Anatomy of perforators, it's earlier we have a lot of names to name these perforators, but for the description point of view, now we call it as thigh perforators, calf perforators, and lateral perforators connecting to short saphenous vein. So as you can see here, this is called spider veins. You have dilated venules causing like cobweb appearance, which is also called as telangiectasia. This is about less than 1 millimeter in diameter. In the second picture, you can see the reticular veins, where a bit more larger veins, which is 1 to 3 millimeters in size, in diameter. So the techniques of perforator ablation are now evolving with time. Earlier, they have done subfascial endoscopic perforator vein surgery, which is called SEPS, which is no longer practicing anymore. Now we do percutaneous ablation of perforators, either by thermal or non-thermal methods. SEPS has been introduced by Power in 1985, and it is done under general regional anesthesia. That means spinal. We use double or single endoscopic port techniques, and with the endoscopy, we do balloon dissection by using carbon dioxide insufflation, about 30 millimeter mercury. And we apply a pneumatic tourniquet to get a bloodless field. And the occlusion of perforators is done by the clips or either harmonic scalpel. Following the procedure, we do compression and ask the patient to mobilize for at least 3 hours. So as you can see here in the picture, we approach the perforators through the endoscopy and then balloon dilatation and dissect in the subfascial plane to visualize the perforators, and then apply the second port or either on the same port. We do clipping or harmonic scalpel division, which is no longer practicing anymore after coming with the emergence of new techniques like laser, RFA, and foam. So the PAPs, as I said, it's basically done under local anesthesia, and ultrasound guidance is necessary. We start with reverse Trendelenburg position and then turn the patient to Trendelenburg when the intervention is done. So always we have a needle tip, and it is kept located at the or just below the fascial layer to avoid damage to the deep vein and the nerves. Radiofrequency ablation can be used to treat the perforators. So intraluminal placement of RF stellate confirmed by ultrasonically. Then local anesthesia infiltrated around the stellate. Then the patient is turned to Trendelenburg position, and with RFA, the temperature is about 85 degrees Celsius. And in the vein, the perforator vein is ablated in the 4 quadrants for 1 minute. And then the stellate is withdrawn for 1 to 2 millimeters, and the procedure is repeated. And we apply the compression. Endovascular laser ablation for the perforators also can be done. We use 16 gauge needles for 600 micrometer laser fiber and 21 gauge microcatheter needle for 400 micrometer laser fiber. Again, the placement is confirmed with the ultrasound machine, and we can also identify the location by aspiration of the blood at or just below the fascial level. Again, the same procedure, local anesthesia infiltrated. We use pulse technique, generation of 15 watts for 4 seconds pulse interval, which will give 60 joules for the time. And we do it twice at the same location, which leads to 120 joules. And then we retrieve the probe and do it in 3 segments following compression. So the complications, as discussed by Sajid, you all know the heat-induced thrombosis and skin complications are common with thermal ablation technique. Ultrasound-guided foam injection, we use detergent sclerosant. We commonly use STS, sodium tetradisulfate, and polydecanol as well, but not available in Sri Lanka. We use 2 syringes connected with a 3-way tap, and liquid sclerosant to air ratio is 1:4, and the mixture is oscillated in between the syringes, which is called a Tessari technique. And then after making the foam, we inject foam by using very small gauge needles to the perforator, as well as the 30 gauge needle can be used to give the foam to small veins, as I said, in reticular or spider veins. The foam is actually increasing the potency of the treatment because better than the liquid, because it will displace the blood and it will act on the vein wall, causing fibrosis rather than clot formation. And at the procedure, we keep the leg elevated to avoid the deep vein, avoid the flow into the deep veins. And then we apply compression. Complications of foam, as you know, it can cause anaphylaxis, DVT, skin pigmentation, and tissue necrosis can happen. It's basically due to arteriolar injection. And certain rare neurological complications also been described in the literature: blurred vision, migraine, TIA, and CVA. These TIAs and CVAs is basically they describe because of the right to left shunt, but it's not and gas embolism because of the shunts. But even in thermal ablation techniques, there is gas generation, and you can have this thing in thermal ablation, but it's not described as such. So they have described this because of endothelium and inflammatory modulation due to foam. I think that's all for the non-truncal reflux disease management. Thank you very much.
Thank you, Margaret. Can I just ask you on behalf of the audience, how do you select clinically significant perforators for treatment? In the sense, when you see perforators, how do we decide whether it's clinically significant or not?
So we can assess the perforators by doing the duplex imaging, and if it is more than 500 milliseconds reflux in the perforator veins, it's clinically significant. So when to treat the concomitant truncal veins as the perforators is clinician's decision. If the patient, we can't bring twice, we usually do it at the same go. But if the patient is a young patient and does not have an ulcer, we might do the truncal veins first and see how he respond to the treatment, and we can wait for his progress.
Yeah, absolutely. I think there's a separate section on a clinical case discussion. We can discuss that there. Generally, I agree with you. Perforators, there's no necessity to treat all perforators. Majority of perforators do actually close up on their own once the trunk is removed. So it's like you take a main road and by roads. If you close up the main road, very likely the by roads are also going to be closed up, something like that. So once you close up or ablate the trunk of the great saphenous or the short saphenous, more often than not, the perforators also get thrombosed with time. But clinically significant perforators are when there are persistent perforators which are refluxing, especially with an active ulcer or under a healed ulcer, despite treating the trunk. So then only you can decide to do targeted treatment for the perforators. Yeah, thanks. So thanks, Malak.
Thank you.
Any questions from the audience? Okay, so we'll keep, anyway, if there are questions, keep it to the end. We have a separate discussion section at the end. We'll go on to the next talk.
And it says US.
That's mine, I think. Yeah. Yeah, so good morning, everybody. So my task is to give you a very short introduction because, I mean, if you start talking about guidelines of varicose veins, it's going to take a long time. And anyway, it's not necessary to do all that because there are lots of guidelines and it's very easy to just see it on see it off the web or in any book. So I'll just touch on some areas, some salient points. So, like I said, I mean, there are lots of guidelines going around. There is an American Venous Forum guideline. There's a NICE guideline practiced in the UK. There is an ESVS guideline, European Society. There is a separate Asian Society guideline. So there are lots of guidelines for management of varicose veins. By and large, it's the same with very minor deviations. So let's not split hairs about those. I like to go by the American Venous Forum guidelines, which I think is very comprehensive. And most of the next 5 or 6 slides are based on that. So I think as trainees, as well as clinicians now, we should really start practicing and describing varicose veins in the CEAP classification rather than just saying mild varicose veins or severe varicose veins. That's very vague. What is severe to you may not be severe to me. Or what is mild to us may not be mild to the patient. So we should have a uniform across the board way of describing varicose veins. And that's the first thing that they recommend in the guidelines, that whatever you do with your varicose veins when you're diagnosing and describing, the classification has to be across the board uniform, so that even if a patient comes to me and then subsequently goes to another clinician in another month or so, the diagnosis remains the same, the classification remains the same, and the management plan more or less remains the same. So we need to know about this C to 6, not to C6 classification. Most important ones obviously are going to be C2 onwards. C0 and C1 we hardly ever see. I mean, C1 we see the telangiectasias and the spider veins that Malak was talking about. That's mostly C1, the ones who come for cosmetic concerns, saying spider vein. So that's, unless it's cosmetically disfiguring and bothering to the patient, you don't really need to treat that. C2 onwards are the proper varicose veins, but again, majority of those don't require any treatment unless the patient is really symptomatic. C3 onwards only, your real proper clinical features start with edema and skin changes. And when it comes to C5 onwards, those are the complicated varicose veins with either a healed ulcer in C5 or C6 with an active ulcer, or C6R, which is a recurrent ulcer. So majority of the patients that we get as clinicians is C4 onwards, C4, C5, C6. And that's where you really need to definitively think about treatment. So whenever you see a patient, even from an exam point of view, or even from a post-MD clinical point of view, I would recommend whenever you see a patient and diagnose, always categorize them as either C2, C3, C4, C5, or C6. Then you don't need to say a lot of other things. The moment you say this patient is having grade 7 reflux with C5, right, he's got a healed ulcer, and you need to do something before the ulcer becomes reactivated again. So it's very descriptive with that kind of classification. So this is just again to drive home the point from C0 to C6. Then about scans. Now, the next thing in the guideline is that generally, unless it's a telangiectasia or a spider vein, all patients who are being contemplated or considered for treatment requires a scan. And the gold standard or the diagnostic test of choice is a duplex ultrasound scan. And how you define reflux is more than 500 milliseconds. That is more than half a second of reflux in the truncal veins. So the trunks are the great saphenous and the short saphenous. It's very easy. If you consider your varicose veins, you can think about either junctional reflux, truncal reflux, or non-truncal, non-junctional reflux. So the junctions are the SF junction and the SP junction. Trunks are the great saphenous vein and the short saphenous vein. Then the non-truncal segments are the perforators and anything else. So when you consider that the trunk, the great saphenous vein, or commonly called the long saphenous vein, or the short saphenous vein, those are the two trunks. And if you can demonstrate more than 500 milliseconds, that is more than half a second of definitive reflux as seen in this image above, that's considered significant reflux. It's a little different to deep veins. If you are considering diagnosing deep vein reflux, especially after a patient who's had previous DVT and so on, then you need to demonstrate more than 1 second. So anyway, we won't go into deep vein reflux here because the topics today are just simple varicose veins. Then the question that we discussed with Malaka earlier was about the perforators. How do you define a clinical perforator or clinically significant perforator? Again, it's a perforator which demonstrates more than 500 milliseconds or more than half a second of reflux, generally also more than 3 to 3.5 millimeters in diameter. And the Doppler ultrasound has to be scanned, has to be done in the standing position, not in the seated or lying down position, which most radiologists do. So it has to be done on the standing position, and the deep venous system has to be scanned properly to exclude a coexisting deep venous reflux or deep venous disease. So very busy slide. I'm not going to go into this. It's just like I said, don't bother too much. All this is available in the internet and most of the guidelines which are freely available to download. So I'm just going to drive home some salient points only. The treatment methods that you have for varicose veins. Once you decide that the patient deserves or requires treatment, there are certain treatment methods that are available to you. So starting from a simple compression therapy to veno-active drugs, to sclerotherapy, to foam sclerotherapy, to thermal ablation, to non-thermal ablation, to surgery. So that's the spectrum of treatment you have. How you decide on which one is best suited for which patient depends on obviously the category, the C0 to C6 category, as well as the affected anatomy, whether it's a trunk or the non-truncal or junctional reflux and so on. So going one by one, this is the evidence in the guidelines about compression therapy. So compression therapy as a standalone definitive treatment is not recommended unless the patient has a contraindication or a definitive limitation against other treatment methods. Best example is let's say a pregnant woman coming with varicose veins and the baby is still inside. You obviously don't want to give her foam or radio frequency or laser or surgery or whatever. And hence you can, until the pregnancy is over, put them on stockings. Or the patient is having some other major illness, planning for a surgery and let's say planning for a laparotomy for a malignancy or something. So, you don't really need to consider varicose vein treatment at that stage. And then for a temporary control of symptoms, you can use compression therapy. But generally, there is no definitive evidence to use compression therapy or compression stockings as a standalone treatment, unless, as I said, if the patient has some other underlying illness or condition that prevents definitive treatment. Then there are veno-active drugs. There are lots of veno-active drugs, pentoxifylline, Deflon, different drugs around. Again, minimal evidence. I would say negligible evidence, but they have in certain limited level 2, level 3 kind of evidence in case series and small trials, small randomized trials. They have shown that these drugs do improve venous tone, has certain anti-inflammatory properties, and that they may, I repeat, may, not that they will, but they may give some benefit in preventing recurrences, and especially for patients who have varicose veins who are being treated with something else, like let's say a foam ablation or thermal ablation. You may use these drugs to prevent recurrence or minimize recurrence, but definitely not as a definitive procedure. So again, take-home message is compression stockings and veno-active drugs, when it's available, do have a very small place, not as the primary treatment modality, but as a stopgap measure or as a supportive measure after your definitive treatment. So comparing the other treatment methods that Malik was and Sajid were describing earlier about the truncal reflux. I'm just going to stick to the truncal reflux now. That is again, from the truncal reflux, also mainly the great saphenous vein reflux. So the common ones that we have at our disposal and what we do routinely are the endovenous laser ablation, radiofrequency ablation, and ultrasound-guided foam ablation. All three of that we have. Cyanoacrylate glue also we had, but we don't currently have. But again, it's cyanoacrylate glue all over the world is going out of favor because of various complications. So nowadays it's mainly going to be either laser or radio frequency. And this famous landmark trial comparing those in 2011 shows the comparison between EVLA for laser, RFA, and surgery and foam in terms of 1 year recurrence rate. You can see foam has a very high recurrence rate as expected, about 16, almost coming close to about 1/5 of patients recurring after 1 year. Whereas EVLA, RFA, and surgery almost equal. Hardly any significance there. Mean postoperative pain scores, again, surgery and EVLA surprisingly more or less the same. I would have expected EVLA to be less, but this shows that it's more or less the same pain score. RFA was much less. That anecdotally also, I can tell you, I do a lot of RFAs, not a lot, but I do a handful of RFAs, and they do have significantly less postoperative pain. And foam, obviously, hardly any pain at all. The median time to return to normal activity, again, surgery 4 days, as you can expect, due to anesthesia, the spinal anesthesia, the 2 groin cuts if it's a bilateral, and so on, compared to EVLA, which is 2 days, and RFA 1 day, foam 1 day. Time off work, similarly, significant differences, surgery 4.3 days, EVLA and RFA 3.6 and 2.9 days. So again, the gist of this is that all these treatment methods are available for definitive treatment, that is laser, radiofrequency, foam, and surgery. Surgery will obviously give you a little bit more pain and keep you off work a little bit more, and the time to ambulate and get back to normal activity will be a little bit longer. And nowadays it's going out of favor, obviously, and we routinely practice laser and RFA. Hardly any difference between RFA and laser, apart from the fact that RFA generally gives a little less pain postoperatively. But ablation rates, the recurrence rates after 1 year, are more or less equal among laser, surgery, and RFA. Then what do the guidelines actually recommend? The guidelines I talked to you about, the American Venous Forum, ESVS, as well as NICE, all the main 3 guidelines. What they recommend is the first choice, always offer endothermal ablation, that is radiofrequency or EVLA, for the great saphenous vein and the short saphenous vein. So the first line treatment, if the patient is fit, and if you deem that the patient requires treatment, the first line treatment is always going to be, or first choice treatment, I would say, would be thermal ablation with radiofrequency or laser, whichever is available to you and whichever you're comfortable with. If endothermal ablation is unsuitable for whatever reason, then offer ultrasound-guided foam sclerotherapy. So this is not simple sclerotherapy given for the superficial veins you see. If you're treating truncal reflux, remember trunks are deep. So you can't just give foam to the superficial vein and hope that it goes into the trunk. If you are going to ablate the great saphenous vein or the short saphenous vein with foam ablation instead of thermal ablation, then you need to do it ultrasound guided. So because one thing is you need to make sure you are injecting into the proper the superficial vein and not the deep vein, and secondly to know that you are effectively ablating the great saphenous vein. If in patients with reflux below the knee, great saphenous vein, ablation is needed to the lowest point of reflux, and non-thermal techniques are preferred for ablation of reflux in distal calf saphenous vein to avoid thermal nerve injury. So basically, below the knee, the calf area, you don't use radiofrequency or laser. You mainly use foam. Above the knee, you use thermal ablation, radiofrequency or laser. Epiphyseal veins are the very, very superficial veins, the really superficial veins. You can't use thermal ablation here. You can't use laser or radio frequency because it causes skin damage. So those ones generally either you use foam or you use ambulatory phlebectomy. So a small stab incision and pull out the vein. Asymptomatic patients, C2 patients, prophylactic intervention does not prevent progression of venous disease. That's very important in the guideline because sometimes patients come and say to get the treatment to make sure that it doesn't progress in the future. So the guidelines definitely say that's no, there no indication to do that just for prevention of future progression. What you do instead is tell the patient about weight control, compression stockings to minimize progression and symptoms, avoiding prolonged standing, and only if the patient has cosmetic concerns that you can treat. So these are the asymptomatic patients, no pain, no edema, no ulcer, nothing. You don't offer them treatment to prevent future progression. You tell them to lose weight, tell them if possible to avoid standing for prolonged periods. If at all, tell them to use stockings, that's all. If they have a cosmetic concern, yes, you can treat it. That's all. So that's about that's a very superficial, a superficial talk on superficial veins. Okay, on the available guidelines, the different guidelines, and I'm happy to answer any questions if you have, either now or at the end of the session. Any questions? Anyway, like I said, you can keep your questions aside. We can discuss it during tea or in the break or even afterwards. Then due to time constraints, we'll move on to the next talk. Prof. Resny is going to talk about venous ulcer management.
Hello again. Since we're running behind time, I'll try to make it quick. So venous ulcers. So this is part of the bread and butter of vascular surgeons, right? So we treat a lot of ulcers. So anyway, let's see what the evidence says. So first of all, what is an ulcer? The American Venous Forum has defined it as a full thickness skin defect, most frequent in the ankle region, that fails to heal spontaneously. Now, usually skin defects will heal spontaneously, but here it doesn't, and sustained by chronic venous hypertension, as based on ultrasound scanning. It's a debilitating problem, and from venous hypertension, this is the worst problem that you can get, an ulcer. And about 35% of the patients, young patients, less than 40, who have venous disease will get. Imagine your plight when you are less than 40 getting an ulcer, and then your work and quality of life and all. So it has a considerable impact on quality of life. So in any culture, people with wounds are, now it's much less than before because earlier wounds were connected to leprosy. So now it's different, but still these people find it difficult with oozy venous wounds to get into buses and stuff like that. They are looked down upon, and the smell. So what are the risk factors? The advancing age, as you age, family history, prolonged standing, increased BMI, smoking, sedentary lifestyle. So even if you have varicose veins, if you are active walking, so that gets your calf pump going, you can prevent, and losing weight prevents such problems. And pregnancies and low extremity trauma are other risk factors to develop ulcers. Now, why they get it is there are two theories mainly. Fibrin cuff theory says that as the venous hypertension dilates the system, even the capillaries dilate slightly, and the pores between endothelial cells gets wider. So when these pores get wider, macromolecules start getting out. Out of it, fibrin is a big molecule. Even that gets out and causes, makes a cuff around the capillaries. So then diffusion of oxygen, nutrition, and diffusion back of bad metabolites like carbon dioxide and other toxic metabolites going out of the system all are impaired. So that is one of the theories. Nobody knows really. White cell trapping theory is what they say is with high venous hypertension, white cell adhesion molecules increase in the endothelial cells. So white cells get trapped there. So you know when white cells get trapped and beyond a critical number, they start getting activated and then release a lot of proteolytic enzyme that digests all these ground substance and then cause release free radicals that damage further and causes ulcers. Other possible causes are arteriovenous shunting because of the venous pressure. And the diffusion of growth factors will be less. So the legs are, when you get an ulcer, legs are generally edematous. You very rarely, you still get normal looking legs. And it classically occurs above the medial malleolus. It is not gangrenous. And the pulses are generally there and it's very warm. So with this ulcer, you must look for stigmata of veins. Now we passed that. This is a bit of overlap. So these, now the feature, the pulses are there, skin perfusion is normal, ABPI is normal, near the medial malleolus, rarely on the lateral malleolus if you're talking on the short saphenous system. Margins are large and irregular, and it's yellow and wet in appearance. It's very wet. And the ulcer exudate is moderate to large. That is another clue that there's a lot of fluid coming out of this. And the skin will show signs of venous hypertension. Pruritus is a feature. Sometimes the moderate to severe edema and pain is an issue. So when you're managing these patients, don't forget to look into their pain. So these are irrelevant to us because in other countries they do plethysmography, try to check the venous recovery time, ambulatory venous pressures and all those things. But for us, the gold standard is venous duplex ultrasound just to find out whether it's a deep vein thrombosis that is causing the venous ulcer or deep venous reflux or something like Mayther's, or more commonly the superficial truncal reflux which is causing these ulcers. But the treatment of the ulcer, the principles are the same. The time principle, tissue debridement, if there is slough, you remove slough. Necrotic area, very rare, you can remove. If there is infection and inflammation, there is inflammation but no infection. If it rarely gets infected, you can treat it. Then moisture balance. If there's excessive moisture, the dressings that you have to put is something that can absorb lots and lots of gauze, or you have weight for weight like alginates or anything that absorbs high exudative fluid you can put. Or if you don't have such dressing, frequently change it so that don't let it get wet. And manage the end of the wound. So what are the conservative methods which we generally use? Earlier, long before maybe 20, 30 years ago, mainly so elevation of the legs, the foot end should be elevated. So this decreases the exudate, decreases the edema, and accelerates the regression of skin healing. And once then we strap these patients. So strapping means ideally you should put a dressing, then you put your crepe bandage, then you put your stocking, then an elastoplast. These are 4-layer strapping, but it's very costly. So at least after the dressing, a crepe, keep it compressed. And once you keep it compressed, walking with that strapping helps because the venous pump works. So when you have a strap patient, you should not keep them in bed. If you are not strapping, you must keep them on bed for a long time. So actually, if you some of these patients who are very highly, very painful ulcers, what we do is admit them for about 6 weeks and they heal a lot. Then some people even use extreme measures like Unna boot, 3-layer Unna boot. What is the evidence? Now, for what are the recommendations? So patient with active venous leg ulcer, superimpose elastic compression stocking, the target pressure should be 40 millimeter Hg. It's very, very difficult to achieve with a crepe bandage. The maximum we can achieve with a crepe bandage is about 15 millimeter Hg. So we fall less than half the distance from that. Then and for patients with active venous ulceration, the anchor pressure less than 60 millimeter Hg, we should not exceed we should not put pressure if the ABPI is 0.6 or less. So you must have ABPI 0.7 or more for you to strap these patients. Okay, what happens if you have a less ABPI, like 0.6, 0.5, how do you do this? Then for those people, the recommendations class 2A is you can use intermittent pneumatic compression. So if long-term compression is not available, cannot be used or fail to promote ulcer healing, intermittent pneumatic compression also can be used. So for patients with mixed ulcers with coexisting arterial disease, modified compression therapy under close clinical supervision. So now, if it's a mixed ulcer, you can't just strap and send them. You should closely monitor what's happening because some of these whole skin, the large ulcer can get very wide. But all these can be done if the ankle pressure is 60 millimeter Hg or above. If it's less than 60 millimeter Hg, you need to do arterial revascularization first and then come back to this wound. And for patients with heel leg ulcers, long-term compression therapy prevents the recurrence. This also has 2A evidence. Now, the EVRA trial, sorry, it's not EVA, the EVRA trial said the conclusion of this is patients with active leg ulcers treating the superficial. So now you're strapping, and what you do to the superficial reflux, treating it also accelerates healing. Now, there was a trial done long years back which said there's no time difference in healing, but stops the recurrence. This particular trial showed it accelerates healing and it also prevents the, reduces the recurrent rates. So that is what so it is cost effective, reduces, so all these three things happen. It heals faster, recurrence is less, and it's cheaper. So it's much cheaper to treat the patient, the strapping and the venous intervention. So what are the venous interventions we are talking about? Now here on the right side, you see the healing rates when you compression plus and without the compression. Then what are the venous interventions you can do with ulcers? Now, under the ulcer, sub-ulcer, there is a venous plexus in some patients. So when you scan, if you discover that, giving foam sclerotherapy, because final common pathways to this venous plexus to the ulcer, it doesn't, the venous pressure. You can give foam sclerotherapy and thrombose that plexus, it will be okay. Then with active ulcers, we have to treat the truncal, either the short saphenous vein and the long saphenous vein, it should be treated. And some of these patients with deep venous resolved DVT or May-Turner syndrome is where the artery, the left common iliac artery compresses the right common vein. So there is high pressure in that system. So it can cause DVT and or decrease venous return. You can stent that segment. And then finally, what we can do is there are adjuncts. There are no evidence, like Dr. Nalaka said, but some people use flavonoid fraction, drug hydrocellular, pentoxifylline. All these can be given. So some studies have showed that there is a benefit, but actually nobody knows. So what do you do when you have an ulcer? You get a multidisciplinary team to check this. So first thing you do is objective arterial assessment. If there's a problem, deal with it. Then you have to treat the venous hypertension. If it's deep vein, you can stent it. If it's superficial vein and truncal reflux, you can do endovenous procedures. Then start on compression therapy. That has class 1A recommendation. Then you may consider additional interventions, adjuvant pharmacotherapy. And if there is no signs of infection, there is no place for antibiotics, and improve mobility, ankle stiffness, and treat obesity. So if they are, tell them to lose weight, we move their ankles, because the more they move their ankles, the more the calf pump works. So, right? And the more they walk, the better it is for their ulcer. So mobility, ankle movement, and obesity. No need for antibiotics. You may consider pharmacotherapy, nothing else working. So compression, treat the venous reflux, make sure there is no arterial disease. So those are the basic principles underlying this. Then this is about if you have a healed ulcer, what happens? Earlier we had. Then treat the superficial reflux. And then what you do to the leg? Now the ulcer has healed. You continue to compress it. If not, it's going to recur even if you treat. Now, nobody knows why. let's say you have treated the truncal reflux and just wait without compression, then again there's a recurrence rate. So there is evidence to show long-term compression treatment reduces the risk of ulcer recurrence. If it's active ulcer, what we said before. Okay, I think it's 10 o'clock. We'll stop there. Thanks. Any questions? So mainstay of therapy is trapping and treating the venous hypertension. Both has to go parallel. Okay, so in treating the venous, the four things you have to remember is there's a subalcer venous plexus, inject it. If it's a truncal reflux, any of the modalities discussed by the previous speakers can be used to treat the truncal reflux. And if it's deep vein thrombosis and causing reflux due to iliac or some, you can stent it, and you may consider adjuncts. And in the last resort, if all these fails, strict bed rest for ileal ulcer is also an option, but it's not practical. Okay, thank you.
Then there is a case discussion.
Cases? There's a case.
No, there's a case discussion. Yeah. You have to go there. So the next one is a very interesting set of cases that we'll try and put these what we talked about. We'll try and put it into perspective and see how we can put it in a clinical setting. I see Prof. Bandig is also there. Sir, can I also ask you to come here? No, just for the case discussion, we'd like your opinions, please. You can talk from there, fine. Okay. And the other panelists also. Sachit, Tilina, Malaka, please. You two of you can sit there. One person can sit here. Come, quick. Okay, so this is just a collection of 3 or 4 cases. We are just going to put what we discussed now in the last 1.5 to 2 hours or 1.5 hours into practice and try to see how we can use this information that we discussed or the facts that we discussed, how we can put it into practice. Okay. So I know the panelists will have to turn around and see 64-year-old female, pain in both legs with ankle swelling, progressive for 2 to 3 years. Her main complaint is she is unable to climb stairs or walk. There's pain in the ankle and the knee. She's got multiple varicose veins in the legs, and she's very worried about these varicose veins. And her main complaint is that she can't climb stairs, and she's got this ankle pain, and she's got this very big, severe varicose veins. Malaka, can I start off with you? How will you proceed?
Musculoskeletal pain. So I need to first make sure that it's not musculoskeletal pain that she's having. And it's mainly if it's mainly the musculoskeletal pain, I will explain the patient and say that whatever we do for the varicose vein will not, cure her problems. So,
Elena, what do you think?
So varicose veins and leg pain, that is a very common presentation. So usually what the patient can see is the varicose vein. So they tend to attribute all lower limb symptoms to the varicose veins and they come to you. So you have to carefully select the patient who will benefit from venous intervention. That's what I feel. So especially in females, they have osteoarthritis, elderly females, obese, elderly and female. They have osteoarthritis, and that is the commonest etiology for the low limb pain in this patient group. So if the symptoms are more likely towards osteoarthritis, for example, in this patient, there is pain when she climbs upstairs. Some patients have difficulty in getting up from the squatting position. So those symptoms are more towards osteoarthritis. And when you examine, there is obvious crepitus in the knees as well. In these type of patients, I tend to discourage intervention for varicose veins unless it is C4 and above. Of course, if the patient has concomitant osteoarthritis and C4 and above, you have to treat the varicose veins as that is obvious because its skin changes are there. Otherwise, I tend to discourage. They should lose weight. Maybe you can refer them for muscle strengthening exercises. Sometimes I do a rheumatology or a orthopedic referral just to get their opinion as well. Sometimes in young patients in this kind of picture, they have some joint pains and you are not sure whether it's 50-50, like whether it's joint pain or the pain is due to varicose veins. For these type of patients, I give a trial of compression. I ask them to wear stockings and be compliant with stockings, try it at home for at least 2 weeks, 3 weeks, and then reassess. So if they have symptom improvement with stockings, then there is an argument if I offer varicose vein treatment, they might have some improvement. Again, if there is no improvement with the stockings, I tend to discourage intervention for varicose veins.
Yeah, absolutely. I agree. Sir, would you like to come in? Yeah, I think that's a very good answer. That's exactly what we do. You have to be very careful with these old people, especially because they tend to think that everything that they get in the leg or every pain that they get in the leg is due to this varicose veins. And sometimes it's very difficult to convince them otherwise. They get very angry with you when you say, no, it's not due to your varicose veins. They think you're wrong. So
just one
Yeah.
point. Actually, more than the patient, it is our colleagues, doctors who write this into their hands. So, Tilina, one little addition would be what I do is I write in capital letters that this patient's varicose veins is not the reason for joint pain. Because otherwise, the myth keeps getting recycled.
Exactly. And when you send to the rheumatology clinic, what happens is they'll send back to you saying varicose treat karangan. So anyway, that's a common thing. But the take-home message for you guys and girls is obviously that if you have a pain, a vague or not so clear pain with varicose veins, always be clear. Because what you don't want to do is do an unnecessary treatment, unnecessary procedure, and then patient coming back to you after 1 month and saying, doctor, the pain is still there. Now, then there's nothing else you can do. So that's a big problem. So you have to avoid that. Okay, case number 2, 42-year-old man, fairly active guy, large varices in the leg. He's a teacher. He's got bursting type of pain and heaviness in the leg on standing. He's got itching. He's got purplish, blackish discoloration in the bottom area of the right leg, left leg also to some extent. And he's got a small 2 by 2 centimeter ulcer, which is clean and healing. Resni, what will you do?
I feel this is venous in this thing. So for the ulcer, we start strapping and elevate the foot end of the bed, and he's lean, so there no bed. Then I will do a scan and see where the refluxes are, and then treat it. Hopefully, endothermally.
Just to split hairs on that. I mean, just to pick your brain. You said strap and then lift the foot end of the bed. Once you strap it, do you really need to lift the foot end of the bed?
Not exactly, no.
Not really needed. If you strap it, you don't need that, right? Yeah, I mean, this looks fairly straightforward with a healing ulcer. This is basically C6. If you remember my previous talk, this is C6, active ulcer. All the skin changes are there. Sachit, so now he wants definitive treatment. He is a teacher. He doesn't want to just come to your clinic for repeated strapping. What will you do now?
Well, as I said, we have to treat the underlying venous pathology. But after that also we have to ideally do compression, the polyester compression bandages until the wound heals. But sometimes if the wound is not very exudative or it's not very large, in certain peoples, I put them on compression stockings where they can dress the wound at home and wear the compression stocking on top of that, especially in this kind of a patient. But if the wound is very exudative and wound is large in diameter, I recommend polyester wrapping.
Okay, I'll throw in an additional question. It's the school holidays and he wants the treatment done with this ulcer. Will you go ahead?
Sorry, sir, I did. What was?
He wants the definitive treatment done before the ulcer is healed.
Yeah, I mean, we can do. We don't have to wait until the ulcer heals for going for treatment of underlying venous disease. So we can straight away do the whatever necessary. As I said, I prefer to do endovenous thermal ablation if possible. And then after that, we can continue strapping.
Yeah, so that's what the EBRA trial, the so-called the famous landmark EBRA trial showed. Previously, when we were trainees, well, at least when Resni and I were trainees, what we were told is the big ESHKA trial. We were told if there's an active ulcer, no, don't touch the varicose veins, strap until it heals, and then do the definitive treatment. But now the things have changed. The recent evidence from the EBRA trial says that if there's a small healing ulcer, then actually treating the underlying truncal reflux with laser ablation or radio frequency will expedite the ulcer healing itself. So this kind of patient, there is no contraindication to go ahead with definitive treatment of the truncal reflux. Actually, it might be beneficial and it might fasten or hasten his healing process. So duplex scan, he shows bilateral SF incompetence GSV reflux, the treatment options we've discussed. So we'll go on to the next case. 49-year-old woman, housewife, recurrent ulcer in the left leg gate area. Split skin graft done by a general surgeon 3 years ago, unsuccessful, obviously. Currently having an active large ulcer. Duplex shows Gray-Seveners as well as Shaw-Seveners reflux. What shall we do? So as you can see, the ulcer is slightly bigger than the previous guy.
But why have you said strapping versus immediate treatment? We can do both concomitantly.
Yeah, no, forget about the last part. I'm just the clinical scenario only. Just open for discussion. What can we do?
Same as above,
Yeah, basically more or less the same as above. I mean, strapping, pain relief and simple analgesics and so on, and then scan and plan for the definitive treatment. Right, so this is the last one. 52-year-old man, history of DVT. Actually, that should be right leg. That's my mistake, not left leg. So the history of DVT in the right leg 13 years ago, anticoagulated for 6 months. Now having recurrent venous ulcer for 3 years. What's the plan? Sir?
Common problem. There must be incompetent valves following recanalization of the thrombosis. There may be partially recanalized, semi-occluded or stenosed strictured segments in the system. So these, unless they are limited to the iliocaval region, like a Mayturner, which can be stented, right? There is no intervention for the deep veins. The leg needs to have graduated compression permanently. Obviously, you start off with graduated compression to treat this ulcer like any other venous ulcer. it looks clean. Unless there is cellulitis, warmth around it, purulent exudate, you don't need antibiotics. We tend to give antibiotics excessively when we see an ulcer. This doesn't look like, and it's got a healing edge. You can see the white edge, particularly at the bottom part. So I'm sure this is being strapped at the moment and it's doing well. You could put a skin graft on this if the tissue or culture doesn't yield any pathogenic bacteria. So basically, compression to heal it as well as prevent it from coming back. It will definitely come back once you heal it. So skin graft to close it. What about superficial venous ablation in such situations? If there is superficial reflux, in addition to deep venous reflux, there is evidence to show that ablation of superficial reflux might help in healing and reducing recurrences. There is superficial reflux and deep reflux. Okay, when you see the varicose veins, we could give ablative therapy to the superficial veins, provided the deep veins are only refluxing, not occluded. Right. So on duplex, you can see dilated veins with antegrade flow down reflux. If there is long saphenous vein in this person with upward flow, dilated vein, you can diagnose superficial femoral vein occlusion. Right. Am I clear? The SFV occlusion is characterized on duplex with antegrade flow in a dilated long saphenous vein, not a reflux vein. Okay, that's a collateral, main collateral. So that's the one that should not be ablated, right? So I'm talking about refluxing superficial veins. They can be treated by the methods that we have already discussed, even in cases of deep reflux. So treatment of the ulcer, infection, bacteria management, compression is the bread and butter treatment of this ulcer. If it's an intervention, superficial reflux can be ablated, despite deep vein reflux. If the iliocarpal region shows any stricturing, narrowing, in these patients, if you stent it, reported results, I mean, we don't have any experience, reported results are remarkable, if that's the case. Of course, diagnosing it is difficult for us. You need to have CT or MR with oblique views. Intravenous ultrasound is now the latest addition to assessing this segment. So centers where the facility is available, they would do these investigations routine for this kind of case. And so that's what it is.
So you said you would graft this ulcer. You would do a skin graft. If you are going to do at what stage? And
when it's granulated, I mean, that looks pretty close to, because you can, this will take another how many months to heal by second intention. It's a huge lesion.
No, it's very important what Prof said that you grasp that. So some time ago, what we were told or what we were taught is if there is evidence of DVT or past history of DVT and now there is a venous ulcer, don't do any treatment for the superficial veins. Now the thinking has changed. So there's almost like a paradigm shift. Now it's changed. So now even if you have had DVT in the past, even if there is deep venous reflux on scanning, if there is coexistent superficial venous reflux also causing ulcer, you can treat the superficial vein with the formal things that we discussed, either laser or foam or whatever, provided the deep vein is only refluxing and not occluded. Okay, so you have the deep veins, superficial vein. You scan it, deep vein is also refluxing, superficial vein is also refluxing, and there is an active ulcer. So what you're trying to do is making sure the deep vein is patent. It's refluxing but patent, not occluded. So it's flowing something. So as long as it is not occluded and flowing, even although it's reflux in the deep vein, you can get rid of the superficial vein that is immediately underneath the ulcer and at least aid the healing process of the large ulcer. So that's a fairly common thing that we get nowadays. Patients with past history of DVT, or sometimes they don't even know. So they have chronic venous insufficiency, large ulcers, recurrent, 4 to 5, not 4 to sometimes 10, 15 years. It heals, then comes back in a month, heals, comes back in a month, like that it keeps going. And immediately when you see the leg, you see this massive swollen, dark purple leg, complete skin changes, even though they haven't been diagnosed with DVT in the past. Obviously, they have been missed or they have never gone to the proper place. You can clinically make a judgment and then you can confirm on your scan. So yes, so even with a past history of DVT, if you do have superficial vein reflux, there is a place, there is a limited place for treatment of the superficial vein reflux in order to help ulcer healing. Okay, so that's the end of the case discussion. I think now we are going to go for a break and come back for the deep VNS session.
There
I
are
think it would be
two
useful
questions.
for you to write a little note
Questions from
for
Ken.
yourselves,
Guys?
clear in your heads. Write notes on, you could get this question, so. Write notes on venous interventions in the case of a post-phlebetic, that means a post-DVT leg ulcer. Write notes on venous interventions, not wound care, not compression. Those are basic stuff, right? Vein interventions that we discussed.
There is a question from the online audience. Yeah.
There are two questions from Candy. The first one is, what is the evidence for SF ligation without stripping?
Resni, would you like to? Yeah. Yeah.
30 years ago, the randomized controlled trial. I know it because when I was a registrar training in England, the trial was going on, and that's where I learned to do venous duplex. They randomized patients to the two categories, ligation only, ligation and stripping, and showed after follow-up that the long saphenous vein reflux in the vein left behind continued after pure ligation. So superficial reflux was not effectively treated with ligation alone. That is because there are other connections, and the vein, once dilated, continues to reflux. It doesn't revolve back to its original position. So that's not effective. Truncal ablation is the important thing, not even ligation of the junction. The trunk needs to be ablated.
The second question they ask is, what are the possible interventions for recurrent varicose veins?
The question is possible interventions for recurrent varicose veins. Resni?
What I would do is scan and see what you have, and then depending on that. So the same principle as how you do the primary varicose veins. If it's straight and amenable to endovenous laser, you laser it. If not, if it's very tortuous and all, you can do foam therapy. And if it's under the skin, easily you can avulse them. So the same as primary. Doesn't
Yeah,
matter.
absolutely. I also agree. I don't think there is any change in the management plan, whether it's primary varicose veins or recurrent varicose veins. Even if a patient comes with recurrent varicose veins after previous stripping or laser or radiofrequency, what you do is you scan it, find out whether it's a truncal reflux or non-truncal reflux, and treat it accordingly. So if it's a truncal reflux, same concepts as primary varicose veins, you do thermal ablation, laser or radiofrequency. If it's non-truncal reflux, you do ultrasound guided foam ablation. Very simple.
Do you think that's the place for redo SF ligations now?
As a policy, I don't do SF ligations. I haven't done almost for 20 years. But
It's a
My,
dangerous.
I mean, there's very limited place for SF ligation, I would say right now.
Chance of
Especially if it's a recurrence after previous SF ligation, going in and doing a drawing dissection again and trying to do SF ligation, I don't think there is a place, especially when you have much less invasive techniques like foam and laser.
Redo surgery. I've done lots of redo SF ligations. Fun operation, but deadly because you can get into serious vascular injuries in that. But there's a way of doing it. But forget it. I don't think we need to do that because there's a lot of newer vessels there most of the time. New vessels, tiny ones. And foam will spread into all these and ablate. And you foam, the good thing is you can keep on repeating it. And it's comparison to all the other methods, they're cheap. Simple, cheap, can be repeated.
And one thing I think we didn't mention during any of the talks is, I think all of us will agree, we do our own scans for when it comes to varicose veins, and whether it's primary or recurrent is very important. I mean, I can't emphasize that enough. It's very important that the clinician who treats the patient does his or her own scan. There's no other way somebody else can from somewhere else say this is this refluxing. You have to see what you're treating, and especially with ultrasound guided foam and laser and radio frequency, you're the one who's treating. You need to know exactly what's there. So you do your own scan. So what I would encourage you, if you ever do vascular surgery, is start learning your scanning skills. Okay, we can break up and come back for the deep vein session.
So shall we start to start the deep vein session? I will be talking about deep vein thrombosis. So this is a very important topic. I'm sure most of you will encounter patients with deep vein thrombosis in your practice. So a little bit about the anatomy of the lower limb veins. So if you take the leg or the calf, there are paired veins around the three named arteries of the leg, the anterior tibial, posterior tibial, and the peroneal. And in addition to these paired veins, there are venous sinuses in the gastrocnemius and the soleus muscles. So these venous plexuses, they tend to drain into the peroneal vein, and the named calf veins will join behind the knee to form the popliteal vein. The popliteal vein can be single or it can be double, and the popliteal vein as it passes through the adductor canal, it becomes the femoral vein. So the term superficial femoral vein is a misnomer. It should not be used. The femoral vein is joined by the deep femoral vein, and the result is the common femoral vein. Once the common femoral vein passes beyond the inguinal ligament, it becomes the external iliac vein. A little bit about the epidemiology of deep vein thrombosis. So in Western countries, the annual incidence of symptomatic first deep vein thrombosis in adults is about 50 to 100 cases per 100,000 population. The risk of recurrent DVT is 10% in the first year. So about 50% with patients who have image positive findings of deep vein thrombosis tend to be asymptomatic. And up to 10% of all lower limb deep vein thrombosis can end up with a pulmonary embolism. So how do you explain the pathophysiology of deep vein thrombosis? It's simply done by the Virchow's triad, same as for any clot formation elsewhere in the body. Venous stasis, this is usually due to external compression, which can be by a tumor, aneurysm, and this was spoken about earlier as well. The left common iliac vein can get compressed from the right common iliac artery. This is called May-Turner syndrome. And the second cause for deep venous thrombosis is hypercoagulability, and the third one is endothelial injury. So what are the risk factors for deep vein thrombosis? So when you take a patient with deep vein thrombosis, and if you can identify a risk factor, that is termed as a provoked DVT. So if you can't identify a reason, then it's termed unprovoked DVT. Classifying deep vein thrombosis as provoked versus unprovoked has management implications because the duration of anticoagulation will depend on this classification. So what are the causes for provoked DVT? Immobility, obesity, malignancy, hormone replacement therapy, OCP, pregnancy, any acute infection, surgery, trauma. And there is a certain set of conditions called thrombophilic conditions, which make the blood more prone for clotting. There are inherited thrombophilic conditions and there are acquired conditions. Examples for inherited thrombophilic conditions are homozygous factor V leader mutation, deficiency in certain anticlotting proteins such as antithrombin, protein C, and protein S. The commonest acquired thrombophilic condition is the antiphospholipid syndrome. So how will a patient with deep vein thrombosis, a symptomatic patient with deep vein thrombosis present? That is mainly with limb swelling and limb pain. So the degree of pain and the swelling will depend on the extent of DVT. For example, a patient with iliofemoral DVT is more likely to have a massively swollen limb compared to a patient with femoral or calf vein DVT. So how do you diagnose deep vein thrombosis? There are 3 tools. There are pre-test probability scores. You can use D-dimer levels and you can use compression ultrasound. The commonest pre-test probability score that we use now is the 2-tier Wells score. There is a 3-tier score as well, but there is no evidence that the 3-tier is better than the 2-tier one. So this is the 2-tier Wells score. There are several factors. You get positive marks, and there are certain factors where you get negative marks. If the total score is 0 or 1, you classify as DVT is unlikely. If the total score is 2 or more, then it is taken as DVT is likely. The second tool that you can use for diagnosis is the D-dimer level. D-dimer is a product of fibrin degradation. It's a very non-specific test because conditions such as pregnancy, any type of surgery, any inflammatory condition can cause the D-dimer to go up. So it's very sensitive, but not very specific. The third tool is compression ultrasound. There are 2 ways of doing a compression ultrasound for DVT. One is the targeted ultrasound scan, where you do a focus examination of the popliteal vein, the common femoral vein, and the femoral vein. And the other technique is doing a whole leg compression ultrasound starting from the ankle and assessing all the veins up to the groin. So what are the advantages, disadvantages between these two methods? The targeted scan can be done very quickly, and you don't need a lot of technical expertise or a hi-fi scan machine to do this scan. The disadvantage of a targeted scan is you tend to miss calf vein DVT. On the other hand, the whole leg compression ultrasound scan will take more time, and you need a good quality ultrasound machine, and you need more technical expertise to assess the calf veins. But you tend not to miss a calf vein DVT with this technique. So when you combine all three tools or all three components together, you can diagnose DVT with a high specificity. So depending on all three, this is a simplified algorithm for your management. So you apply the well score to a patient, and if the score comes as low risk of DVT, you do a D-dimer level. If the D-dimer is negative, you can exclude this patient from having DVT. If the D-dimer is positive, you have to do an ultrasound scan. In a patient with a score of 2 or more or high risk of DVT, you do an ultrasound scan straight away. And if the ultrasound is positive, you treat as for DVT. If the ultrasound is negative, you can do a D-dimer. And negative D-dimer patients are excluded. And if the patient has a positive D-dimer, you have to do a repeat scan after one week's time. So what are the classic ultrasound features of deep vein thrombosis? There are 4 features. The vein will be not compressible due to the thrombus within its lumen. And when you do color duplex, there will be no color flow. And there will be no phasic flow. So if the proximal vein is patent, when the patient performs a Valsalva maneuver, that should be reflected in the lower down veins. So that is not there when there is DVT. And there is no flow augmentation when you do a cast squeeze. So in addition to ultrasound scan, what are the alternative imaging modalities? You can do CT venograms, you can do MR venograms, but in our practice, these are rarely done. So they have a place in probably diagnosing inferior vena cava thrombosis, and they have a place when you want to do deep venous interventions to get more anatomical information so you can plan your case. Contrast venography with a diagnostic intent is almost never done now. You do this when you plan to treat. So the management of DVT will be dealt in the subsequent presentation. I will just highlight few controversial areas with regards to DVT and finish off the presentation. So in a patient with unprovoked DVT, occult malignancy is a possible precipitating cause. So how and when should you screen for malignancies? In our setting, when you get a patient with unprovoked DVT, you can't screen for every malignancy under the sky. So what they recommend is you have to do a focused clinical examination and do a age and gender specific malignancy screening. For example, in an elderly male with unprovoked DVT, probably you should suspect prostate cancer. In a female, probably you should suspect breast cancer or ovarian cancer. So another controversial area with regards to unprovoked DVT is when and how you should test for thrombophilic conditions. So when you talk about screening for thrombophilic conditions in government sector, the tests we can do are again very limited. But what type of patients should be referred for this testing? But basically what the guidelines say is you should do a thrombophilic screen if it affects your management decision. The few examples are in a young patient with unprovoked DVT, if you contemplate on stopping anticoagulation, probably you should do a thrombophilia screening. And in a patient with unprovoked DVT with a DVT family history in first degree relatives, you can do a thrombophilia screening. Again, the reason is if the patient becomes positive, you can screen the siblings or the children and then pick up the cases early. And in a female patient with unprovoked DVT who has a history of recurrent miscarriages or a history of intrauterine death, you should test for antiphospholipid syndrome. Again, because the diagnosis will alter the anticoagulants that you prescribe for these patients. A few words on calf vein DVT, another controversial area in deep vein thrombosis. So calf vein DVT is defined as DVT of the tibial veins, peroneal veins, and muscular venous plexuses. The risk factors for developing calf vein thrombosis is similar to proximal DVT. They have calculated there is a 9% risk of calf vein thrombosis extending into the popliteal and above, and the risk of pulmonary embolism is around 1.5%. So the difference between calf vein thrombosis and more proximal DVT, the main difference is they have found out when the thrombus extend beyond the popliteal vein, the risk of pulmonary embolism goes up, markedly goes up, right? So in a patient with calf vein thrombosis, isolated calf vein thrombosis, how do you take the management decision? Again, it's a controversial area, citing the risk of proximal extension and the risk of pulmonary embolism. Some recommend blanket anticoagulation, same as for proximal DVT. Some recommend repeating another ultrasound scan after 1 week's time to make sure that it has not progressed more proximal. So as a practical rule, in a patient with calf vein thrombosis with additional risk factors, for example, there is an ongoing malignancy, or else the patient is an obese patient, you can consider therapeutic anticoagulation, same as for proximal DVT. The management component will be dealt with in subsequent presentation. So that's it. Do you have any questions with regard to this? Okay, thanks.
Thanks, Dylan. Until we get set up, one of the candidates asked me a question. Sorry, can you ask that question again? Yeah, so the question he asks is, if there is superficial thrombophlebitis, what do you do? So superficial thrombophlebitis, we haven't included in the list of topics today, but it's a very important thing, mostly for practical purposes rather than for exam or whatever point of view. Superficial thrombophlebitis is a condition, a complication that you can get with varicose veins for sure. And it's a very common clinical condition, even in patients who have not previously been assessed for varicose veins. So if you have superficial thrombophlebitis, definitely there is no place for immediate varicose vein laser treatment or radiofrequency or any kind of treatment for the actual varicose vein. If you have superficial thrombophlebitis, the recommendations are you need to see ideally by clinical assessment and a scan the extent of the superficial thrombophlebitis. If it is below the knee and if the length of phlebitis is roughly less than 6 centimeters or so, then you don't need anticoagulation. If it is above the knee and if it is extending beyond 6 centimeters or if it's within 2 centimeters of the SF junction, due to the possibility of extending into the deep veins and causing a DVT, there is some evidence to say then that kind of superficial thrombophlebitis. That means thigh phlebitis, long segment, more than 6 centimeters, and within 2 centimeters of the SF junction. Those three parameters, if there is superficial phlebitis, there is an indication to treat it with anticoagulation, but with a much shorter duration, about 6 weeks compared to the 3 months that you give in DVT. Okay. So the direct answer to your question, if there is a patient who's been assessed for varicose veins and who now comes with phlebitis in that area, what you do is symptomatic management. So symptomatic management includes an NSAID, right, to reduce the inflammation. As I said, if it is a long segment or if it is above the knee, I would give a short duration about 6 weeks of anticoagulant, oral anticoagulant, not heparin, but oral anticoagulants. And if symptomatically bothering the patient, ask the patient to wear a stocking and get about his or her normal activities. And then reassess the patient in about 1 week, if necessary, to do a scan also if needed, and also to see whether there is clinical improvement or progression. That's all. Okay. But you don't do laser treatment or definitive varicose vein treatment when the vein is already phlebitic. Yeah, if it is progressive, generally in my own clinical practice, if it is above the knee phlebitis and close to the SF junction, I anyway put them on a short duration of anticoagulation. That's anyway what was already recommended in the AVF, the American Venous Society guidelines. If it is below the knee, then no, then it's just NSAIDs, and if necessary, a small antibiotic if you think infection is the root cause of the phlebitis and so on. But what Prof. Kasim's question is, if you do a repeat scan and if it is if it's expanding or extending or going close to the SF junction again, then yes, anticoagulate. And one other thing, now that we are mentioning superficial phlebitis, obviously very rarely you get patients with recurrent attacks of superficial thrombophlebitis. Those patients, you need to make sure that they don't have any underlying cause, right? Malignancy and so on and so forth. So anyway, the DVT part, again, DVT, as I said in my previous talk, if you start discussing DVT, it's a never-ending topic. Management, there are so many guidelines, so many societies having their own different guidelines. So within 10 minutes, I'll never be able to finish it. So I've just taken a brief clinical case related talk, about 8 to 9 slides, to discuss how we make these decisions, right? In day-to-day practice, how do we make these decisions? So Tilina was talking about provoked DVT, proximal DVT, unprovoked DVT. So provoked DVT is basically DVT where you can definitively identify or at least with a reasonable amount of suspicion, say there is a certain cause for this DVT. So for example, a person after a fracture, after a long journey, say someone who had just landed in Colombo from an airline flight or something like that. So there is a definite cause identified. So that's the provoked DVT. And also, let's say females who are on oral contraceptive pills and that type of thing. So there's a definite underlying cause that can be attributed to the DVT. Unprovoked is obviously those patients who have no recollection of such history. There is nothing in their history to suggest that they have had any provoking incident, but they suddenly come. And people who go to work, come back, and then next day come to you saying the leg is swollen and they're DVT. So that is unprovoked. Proximal and distal DVT is based on the anatomical location. So anything above the knee generally is considered proximal DVT. So I'm just going to go by a case-based discussion just to keep it interesting. So we have this guy, Mr. X. He's a 75-year-old man with a recent, 1 month ago, admission to hospital for hip replacement. Now, post-surgery, orthopedic surgeon had done the hip replacement. He reports that his right leg has been swollen for over 2 weeks. He thought it was the natural healing process after the operation, but obviously the swelling is getting worse. Okay, what do you think? Okay, so I'm going to keep running because there's no one in the panel, but feel free to put your hands up if you want to ask a question, right? So you believe that patient X has symptoms of DVT, right? It is provoked. He's had operation in the past, a massive operation, a big operation in the hip. So obviously he would have been bedridden for at least a few days and immobile. He's old, 75 years. All those are contributory factors. So very likely that he's had DVT. So what do you do next? So again, Tirino was talking about the two-level DVT well score, right? DVT is mostly a clinical diagnosis with supplementary evidence from either D-dimer or duplex ultrasound scan, right? But the clinical diagnosis is very important. And how you make this clinical diagnosis is by the two-level well score. So you need to know what the well score is. I don't think you need to memorize it as such, but you need to know what well score is, and you need to know at least some of the exclusion criteria and what are the very likely causes of DVT based on the well score. You also want to know, okay, so well score is positive, clinical history is there, you strongly suspect this is DVT, now you want to confirm. So the confirmatory one, again, as Dr. Tirina said, is a duplex ultrasound scan. Duplex ultrasound scan will confirm to you and show the ultrasonic evidence of non-compressible, no augmentation, filling defects, and so on. But unfortunately, if you can't get the ultrasound scan done in a hurry, another thing that you can do is a D-dimer test. D-dimer, although it is not very specific, it is highly sensitive. If it is positive, there is a very high likelihood that you're having DVT anyway. So your DVT is diagnosed. Then now remember, this is a 75-year-old after a hip fracture and hip replacement 1 month ago, right? So now your questions are, how do you treat this DVT, right? So the things that you need to know, things that we have to discuss and remember are, how do you treat the DVT? How long do you treat? And when can the patient start mobilizing? Those are the 3 main questions, right? So diagnosis DVT we discussed, it's about clinical diagnosis of the well score, D-dimer, and the duplex ultrasound scan. Then the initial treatment. Treatment will be either, where you start off with heparin. You start off with either low molecular weight heparin or unfractionated heparin. Nowadays, we give low molecular weight heparin to almost all the patients. We don't actually admit the patients and give unfractionated heparin for DVT anymore. It's largely low molecular weight heparin because of the advantages. Again, I won't go into the advantages. All of you will know the advantages of low molecular weight heparin. It's easy to give subcutaneous as opposed to an infusion. So one jab, you don't need to stay in hospital. You don't need admission. The bleeding risks are less, and so on and so forth. And also the risk of heparin-induced thrombocytopenia is less. The perceived disadvantage, obviously, is if you're unlucky and if you do get a bleeding, reversing is not easy because the protamine doesn't act as well on low molecular weight heparin compared to unfractionated. But still, for all practical purposes, we treat DVT, acute DVT with low molecular weight heparin, generally 1 milligram per kilogram body weight, subcutaneous, given once a day or in certain cases twice a day. Then now you can't keep doing this. You can't keep giving injections for a long period of time. These patients will require anticoagulation for a minimum of 3 months, sometimes 6 months, sometimes lifelong, depending on the case. So then you can't keep giving these heparin injections long term. So you need to bridge them and convert them to a more easily accessible or easily given route of administration, so which is the tablet. Now, until very recently, what we had is warfarin. So warfarin, the problem with warfarin, again, as you know, is it's a very volatile tablet. You need to check levels at least once in 2 weeks. It reacts with almost every other medicine that you take. You have severe dietary restrictions. You can't eat green leaves and things like that. You need to take it on an empty stomach. So patient has to be fasting for 2 hours before and 2 hours after, and lots of problems. So then you have what are called the novel oral anticoagulants, or also called direct oral anticoagulants. So DOAC or NOAC, if you see those terms, those are the new oral anticoagulants, which are much more potent and more effective and has taken away almost all the negative things of warfarin, which is it doesn't react with any other medicine. You don't need to check levels. You don't need bridging. Now, warfarin, obviously, is slow to act. So that's why If you remember your pharmacology, we used to give loading dose at 10 milligram, 10 milligram, 5 milligram on the day 3 onwards, and then wait for the INR to be normal. So that's because it's slow acting. And also when you want to stop warfarin for whatever reason, let's say the patient has been started and now has a bad tooth and needs a tooth extraction, you need to stop warfarin about another 5 to 6 days before, otherwise the anesthetist won't anesthetize because the INR is high and INR doesn't drop for several days even after stopping. So it's slow to act as well as slow to come down, warfarin. So that's another disadvantage. Whereas novel oral anticoagulants like rivaroxaban and apixaban, they are very quick to act. Within 12 hours, they've reached therapeutic levels. Same thing, within 12 hours, they will reverse the therapeutic levels. So the advantage is you don't need INR monitoring, you don't need blood monitoring, you don't need admission, you don't need bridging with heparin and low molecular weight heparin, and it doesn't interfere with your diet, and it doesn't interfere with the other medicines you take. So all those advantages are there. But it's not always as rosy as it sounds. There is a disadvantage to this also. The disadvantage, obviously, it's disadvantages. Obviously, it is very costly compared to warfarin, fairly costly, not freely accessible or available in the government sector in Sri Lanka at least. And thirdly, there is another perceivable problem, which is in case you miss a dose, you're in some amount of trouble. For example, warfarin, one of the indirect advantages is since it is slow to come down, even if you miss a dose today, say for instance, you're on warfarin and you have to go to Anuradhapura to give a lecture and come, you forget to take your warfarin and go, still yesterday's dose will keep you going with at least a decent INR. Whereas the NOACs and DOACs, because their half-life is so slow, if you miss a dose, you're now subtherapeutic immediately. So that disadvantage is also there. But having said that, the take-home message is nowadays, almost all of us are shifting towards novel oral anticoagulants away from warfarin because of the series of advantages that I discussed above. Then there is something called catheter-directed thrombolysis, right? So you may have heard and you may have read sometimes. So if you have DVT, when would you consider catheter-directed thrombolysis? So again, catheter-directed thrombolysis is possible, but would you consider it in this man? The answer is no, simply because this patient is 75 years old. He's had surgery in the recent past, and also the DVT or the presumed DVT, the onset is more than 14 days because I don't know if you remember the initial clinical vignette, which he said the leg swelling has been there for more than 2 weeks. So catheter-directed thrombolysis is available. Remember, there's a difference between anticoagulation and thrombolysis. Anticoagulation, heparin and warfarin and novel oral anticoagulation, those are anticoagulants. Anticoagulation, it prevents new clotting. It doesn't do much to the existing clot. Thrombolytic is the one that lyses the existing clot. So starting from streptokinase to urokinase to tenecteplase to tissue plasminogen activator, those are the ones which will actually lyse the clot. But catheter-directed thrombolysis is not something that you routinely do for DVT. It has a place with carefully selected patients. What I would say is young patients with no contraindications and no evidence of recent surgery to cause bleeding, and less than 2 weeks since the onset of DVT. Otherwise, the clot will not lyse with thrombolytics anyway. Right? So it has to be fairly young patients. I generally, in our unit, we take it less than 50 years. Young patients, otherwise fit patients with no contraindications, and the iliofemoral kind of proximal DVT with the onset of less than 14 days. Those are the patients ideally for catheter-directed thrombolysis, where you, under radiological guidance, you place the catheter, start a infusion of tenecteplase, and then after 24 hours, again, you can pull the catheter down, and you can gradually pull the catheter down gradually, depending on the response, and you can lyse the entire existing clot. And that gives remarkable clinical advantage and clinical recovery, as opposed to keeping the big clot in place and trying to give warfarin or apixaban for a long period of time. What about IVC filters? Again, some patients get referred to us asking whether the patients require IVC filters. IVC filters, again, have a very limited place. IVC filters are not for all patients who have DVT. Certainly not, right? If you can safely take anticoagulation, either warfarin or rivaroxaban, and if you don't have any contraindications and if you don't have complications, and while taking the anticoagulation, oral anticoagulants, if you are not having recurrent symptoms of pulmonary embolism, then you don't need an IVC filter. IVC filter we would consider only if there is a definite contraindication to anticoagulation. For example, let's say patient having DVT following DVT after, let's say, intracerebral hemorrhage and stroke. Okay. Or let's say patient having DVT and recurrent pulmonary embolism with a underlying malignancy, now awaiting surgical clearance of the malignancy. Okay. So if there is a definite contraindication to anticoagulation, yes, IVC filter can be inserted. Second is, there is no contraindication, but patient can't tolerate anticoagulation. Let's say you start on enoxaparin, the patient develops heparin-induced thrombocytopenia. The platelet level keeps dropping, now from 150 to 70, today 40. Then you need to stop. Or patient has severe allergies or some kind of, let's say, active peptic ulcers or something like that, which prevents anticoagulation. Those patients, yes. Right? So there is a very limited place for IVC filter, certainly not for all the patients. Then about graduated stockings. There were lots of trials called SOX trial and so on, which looked at the evidence for graduated compression stockings in the presence of DVT. The initial teaching was, if you wear a DVT stocking, that will prevent a long-term complication called post-phlebitic syndrome. Post-phlebitic syndrome, as if you remember the last slide we discussed on the cases with the man with the large ulcer and the past DVT, Prof. Mandika was talking about post-phlebitic limb. So that's one of the rare complications you get after previous DVT, where your deep veins are affected with DVT. And during the natural resolution of symptoms, your body dissolves this clot, and along with the clot dissolving, it basically eats away or dissolves away your valves also in the deep vein. So now you have a deep vein which has no clot, has no valves also. So now there's a constant reflux. So that kind of thing will give you long-standing complications called post-phlebitic syndrome, where the leg is swollen, recurrently ulcerating, dark color, itching, pain, and so on and so forth. So there was some, thinking, not evidence, but thinking long ago, about 10, 15 years ago, to say that wearing stockings during DVT will minimize post-phlebitic limb. But the recent SOX trial and various trials have shown that it does not do that. It doesn't reduce the post-phlebitic limb incidence. So the incidence of post-phlebitic limb is not reduced by wearing stockings. However, there is a definite place for stockings in symptomatic management, which is patients with DVT with a swollen leg will obviously feel more comfortable when the stocking is on. Right? So it's like wearing a cap when you're going out in the sun, something like that. So you wear the stocking mainly. So you recommend the stocking not to prevent post-phlebitic limb. You give it for symptomatic relief, so that then thereafter, with the stocking on, the patient can be mobilized early. Otherwise, with the pain, he won't be mobilized again. So for that purpose, stockings are recommended. Generally, grade 2 or grade 3 stockings, either below knee or above knee. Again, below knee or above knee, they compared that also, and then found out there is no significant difference between above knee and below knee. So generally, most of us now give below knee stockings because it is more user-friendly. Further screening part, Tilina touched about thrombophilia screening and so on, so I won't go into that. Last thing, the slideshow is over. The last thing is about duration. So another controversial area is how long do you continue anticoagulation? Let's say the patient is diagnosed with DVT today. You started on low molecular weight heparin. After a day or so, you started on either warfarin or novel oral anticoagulation, and now the patient is on oral anticoagulation, adequately anticoagulated, stockings have been inserted, patient is comfortable, can walk, can send home. Now the next question is, how long do you continue this anticoagulation? So the general recommendation is a minimum of 3 months for first-time DVTs. Also, if it is a reversible cause. So, for example, let's say a person, that previous example, the person who has had a hip fracture and got a hip replacement done. So that is a reversible risk factor. The risk factor is no longer there. Hip replacement done. Now he is mobile. Now his hip is good. As opposed to a paralyzed patient after complete stroke, where the risk factor is ongoing, or person with incurable malignancy. Risk factor is ongoing. So if the risk factor is ongoing, the recommendation would be to prolong it either 6 months or sometimes even lifelong, because the risk factor is constantly there. But if the risk factor is no longer there, let's say the DVT happened due to a hip fracture which has been corrected, or DVT occurred after patient flying from London to Colombo, risk factor is no longer there. In that case, definite risk factor identified, risk factor is no longer there. You start anticoagulation minimum of 3 months. If the symptoms have resolved, you stop after 3 months. That's the general recommendation. Any questions? I'm happy to answer.
I think most of the stuff about DVT is touched now, but I'll talk about thrombolysis versus anticoagulation for DVT, a quick one. As Tina discussed, you have a virtuous triad in thrombosis, and what we are trying to do is to avoid thrombosis by correcting these factors. So anticoagulation is for correcting hypocoagulable state. As said, we got indirect anticoagulants, direct anticoagulants like DORAC and vitamin K antagonists. Indirect anticoagulants are the things that you all know, is the heparins, fondaparinux, dalperoid, all require antithrombin as the cofactor for anticoagulation. You can see this cascade here. They all need antithrombin as the cofactor to act on the factor 10A or factor 2A. Direct anticoagulants, they can directly act on the factor 2A as well as factor 10A without the cofactor. So the yellow, the ash color boxes you get oral anticoagulants, that these are the NOACs that Nalaka has discussed. Vitamin K antagonist is the earlier form of oral anticoagulant we used. It inhibits the gamma carboxylation of factor 2, 7, 9, and 10. At the same time, it inhibits the gamma carboxylation of protein C and protein S. So the protein C half-life is short, and therefore, when we start vitamin K antagonists, they usually have a transient period of hypercoagulable state. So we need to make sure that he is on heparin bridging before starting the VKA. Then I'll talk about the thrombus removal strategies. They say the best medical therapy and elastic compression stocking will be suboptimal for the prevention of and treatment of PTS. And even with best medical therapy alone, there will be about 25 to 75% of PTS with extensive DVT. That means iliofemoral DVT. The persistence of the thrombus will be, linked with the valvular injury, and it will cause inflammatory reaction, and it will develop and progress into PTS. So the thrombus removal strategies, as discussed, are the catheter-directed thrombolysis is the main technique of getting thrombolysis. What we do is we deliver a thrombolytic agent through the multiple side hole catheter. The tip of the catheter is be placed in the lumen of the thrombus, and we can use continuous or pulsatile continuous infusion of thrombolytic agent or pulsatile spray injection therapy. They say the pulsatile injection therapy is much more effective in clearing the thrombosis. So we use plasminogen activators like urokinase, RTPA, and we access the thrombus-free popliteal vein or otherwise the posterior vein under ultrasound guidance. Sometimes this CDT can be accompanied with ultrasound accelerated therapy where there's a core wire which emits the ultrasound wave, which will effectively lyse the thrombus. It's an additive effect. Apart from the catheter-directed thrombolysis, we have there are centers they do pharmacomechanical CDT. That means apart from the lytic agent, they use another mechanical cause to lyse and aspirate the clot. So there's a gadget called angiojet where you can lyse when the thrombolytic agent lyses the clot, and the gadget will aspirate the clots at the same time. So this mechanism, the technique will complete the treatment within 24 hours because it aspirates the clot. But as you know, the CDT, the conventional CDT, will take about 48 to 72 hours to complete the treatment. So the CDT versus anticoagulation, there are controversial studies in the literature. The Cavan study has compared the CDT versus conventional anticoagulation, where they said there's a reduction in PTS. There's an absolute risk reduction of 14% at 2 years and 28% at 5 years. But rest of the studies haven't proven much difference when you are comparing the thrombolysis versus anticoagulation. Those ATTRACT study as well as the CAVA study, which compared those methods, they say there's no difference in between the developing the PTS, but obviously they have higher risk of bleeding. At the same time, they have seen there's a less chance of getting moderate to severe PTS. So I think you got my point. There will be no difference in the incidence of PTS, as Dr. Nalakas has said, but they have less chance of getting moderate to severe PTS with thrombolysis treatment. And as said, so the key CDT should be limited to healthy person with no comorbidities, good life expectancy, and who has a higher chance of getting a DVT, the PTS, which is in a patient with an extensive DVT like iliofemoral, and high chance of technical success as the symptom onset is less than 2 weeks, and with low bleeding risk. Thank you very much.
Yeah, thanks, Malak. I think the take-home message there is thrombolysis, catheter-directed thrombolysis is definitely a treatment option in selected DVTs. The idea is to select these patients carefully. So it's not for all DVTs. As I said, and as Malak has said, it's for more proximal DVT, iliofemoral DVTs in relatively healthy people who have been diagnosed within 2 weeks of the onset, right? So, and who don't have any other contraindication. So certainly not like the previous example of a 75-year-old, but less than 50 years, iliofemoral DVT after taking oral contraceptive pills or after an airline flight. Yes, no other contraindications, no bleeding risk within 2 weeks of diagnosis. Excellent results with catheter-directed thrombolysis.
Thank you.
Right. Okay. So I'm here again to discuss a bit unfamiliar topic for vascular surgeons. We don't usually discuss about pulmonary embolism, but here we go. So pulmonary embolism, why is it important? The importance is it has a significantly very high mortality. So the incidence is about 60 to 70 per 100,000 patients, but it has a very high mortality rate, especially when the patients are not treated. So the death rate is about 100,000 to 200,000 per year in the US, where the evidence is there, the statistics are there. So the problem with pulmonary embolism is it's a diagnostic challenge. So all the clinical symptoms and signs are non-specific. So therefore, you tend to sometimes miss the diagnosis and you find the diagnosis in the postmortem where you are too late. So pathophysiology of pulmonary embolism, I'm sure you are familiar with this than me because you are fresh after part 1. So what happens is the pulmonary embolism is commonly secondary to the thromboembolism or a blood clot. But rarely you can get pulmonary embolism from other causes as well. For example, fat embolism, amniotic fluid, etc. But here we are going to focus on the thromboembolism part. So what happens is a blood clot goes and obstruct a pulmonary vessel. It could be a small one or a large main pulmonary trunk. So then what happens is the perfusion stops from that point onwards, but the ventilation continues. So there is obviously going to be a ventilation perfusion mismatch. Okay. So then what happens is the affected part produces a lot of chemical mediators which cause vascular constriction in the unaffected part of the lungs as well. It sort of further aggravate the mismatch. And this will increase the afterload of the right ventricle because the pulmonary, when the pulmonary vascular pressure goes up, it transmits to the right side of the heart. Then what happens? The right ventricular afterload increases. And also with that, the LV filling is also less because the blood comes to the right side, go to the lungs, and then comes to the left side. So when there's an obstruction to the pathway, left ventricular filling also reduces. So then patient will go into shock, myocardial ischemia because coronary artery filling goes down. And end result would be death if not treated. Okay. So as I said, presentation could be non-specific. Patient can present to you with dyspnea, the pleuritic type chest pain, cough, hemoptysis, syncope. And on examination, you will find patient is tachycardic, tachypneic with reduced breath sounds on the affected side, elevated JVP due to right heart failure, and loud P2, right? So as in DVT, we have a diagnostic score systems here. So we apply those, I'll come into that later. And supportive investigations would be ABG. We'll show you hypoxemia, respiratory alkalosis, and hypocapnia. And the D-dimer levels will go up. And because of the right ventricular obstruction, the right ventricular myocardium will stretch and it will elevate the BNP levels, also the tropi levels. And there will be indirect evidence of PE in ECG, evidence of right heart strain and failure, and 2D echo. Okay. So this is a diagnostic criteria. There are quite a few diagnostic criteria available, but the most established ones is the Wells score. This is different from Wells score for DVT. This is the Wells score for pulmonary embolism. And adding up the points, you can say pulmonary embolism likely or unlikely. Okay, so you apply this for patients with suspected PE who are hemodynamically stable. So when the patient is hemodynamically unstable, then what you should do is, you should do because obviously the unstable patients would be either ETU or ICU. So you do a bedside 2D echo to see whether the patient has got right heart failure or not. If the patient doesn't have right heart failure, then PE is very unlikely. You have to find for an alternative cause. So if the patient is hemodynamically stable, you apply this one, Wells score. Okay. And there's another one called Perk rule. Perk rule is to be used in ETU setups, where you can rule out PE rather than diagnosing it. Okay. So when in the ETU setup, if you suspect a patient with having if you have patient comes with dyspnea where you want to rule out PE, you can use that as well. Right. What are the diagnostic imaging of PE? So earlier days, the diagnostic imaging of choice was VQ scan or the lung scintigraphy. Now it has been replaced by CTPA, which is CT pulmonary angiogram. Okay. So it has a very high positive predictive value. That means if it is positive, the diagnostic value is high. So you usually see a filling defect in the pulmonary vessels with the contrast around it, which is called the polo mint sign. I'm sure you know what polo mint is. Where you, the mint with a hole, you know that, no? Right. If a small lung branch, the pulmonary artery branches are occluded, you get evidence of patchy lung infarction. Okay. Right. So once you diagnose the PE, clinically suspect it, then the clinical scores are likely, then you diagnose it. Then the further management depends on whether the patient is hemodynamically stable or not. Okay. So how do you decide that? So there are three criteria to decide that. If the patient has had a cardiac arrest needing CPR, or patient is on persistent obstructive kind of shock, where the SBP is persistently either less than 90 or more than 90 with vasopressors. So then you decide the patient is hemodynamically unstable. So if the patient is hemodynamically stable, then the cornerstone of management is systemic anticoagulation, just like in DVT, together with supportive care. So you can give oxygen via a face mask if the saturation is less than 92% on air. Otherwise, with oxygen also, if the saturation does not pick up, you have to consider mechanical ventilation. And here, very important, you have to give fluids very mindfully. You cannot overload the patient because it will further aggravate the problem, because it will further increase the right ventricular afterload. So therefore, you have to start early vasopressors. Okay. So how do you guide it? You have to check the diameter of the IVC. So if it is underfilled, you can give fluid. Otherwise, still with a filled IVC, if this blood pressure is still low, then rather than overfilling the patient, you have to start vasopressors early, like noradrenaline or something. Okay. Then if the patient has a high probability of PE, even before the diagnostic imaging, you can start anticoagulation. Or if the probability is low, you can wait for the investigations to come. Okay. So agents are the same. You can use enoxaparin followed with warfarin, or else now there is evidence to say DOAC. is equally effective in the treatment of PE, but DOAC is not for pregnant women or patients with malignancies. There you have to continue enoxaparin. Place for IVC filters. If the patient is hemodynamically stable, PE is diagnosed, but you cannot anticoagulate. There's a contraindication to anticoagulate. Then you can use IVC filter. It will not treat the PE, but it will prevent further clots from coming. Okay. Then hemodynamically unstable patients. As I told you earlier, patients with low blood pressure. So the treatment of choice would be systemic fibrinolytic therapy, which is not a catheter-directed one. You give systemic fibrinolytics, just like in stroke management. But if there's a contraindications for you to use RTPA, for example, recent brain surgery, diagnosed brain cancer, something like that, then there are two options to choose with. One thing is a mechanochemical thrombolysis using a catheter directed from the femoral axis through the right heart to the pulmonary vessels, right? If that is not feasible, there's a place for surgical, open surgical embolectomy, which is done by actually cardiothoracic surgeons. There they open into the pulmonary vessels and take the clot out. It's a very high morbid procedure. So anyway, in this category of patients, mortality is high. So prognosis, overall 28-day mortality in the literature is ranging from 18 to 65%, more among hemodynamically unstable patients on presentation. But overall, the mortality is significantly less among patients who are treated. So to treat, you have to diagnose it. And to prevent recurrence of PE, as discussed earlier, you have to do the assessment as to why the patient has got this. If there's any problem in the clotting pathway, you have to identify it by doing the thrombophilia screening, and you have to give extended anticoagulation, same like DVT. So in summary, PE is the third highest cause of cardiovascular death after MI and strokes. It needs high index of clinical suspicion to diagnose it. So risk assessment is essential for proper management to categorize the patients. So anticoagulation early for patients with high probability before even getting the imaging. Vigilant use of IV fluids, I mentioned that, and early use of vasopressin. Thrombophilic screening to prevent recurrence. Right. Thank you very much. Any questions?
Thanks, Ajit. I think that's a very comprehensive talk. Thank you. Since we are running short of time, we'll ask Tilina to sum up. You have a talk, no? Post-robotic limb. Were there any questions up to now, Tilina? Are there any questions up to now? Online questions were there, Tilina?
No, sir, they were on the tab, so they will bring it up.
All right.
Right. Again, I think there will be a lot of overlap, so I will just rush through. So post-phlebitic limb, how do you define that? This is same as post-thrombotic syndrome. It's defined as set of signs and symptoms of chronic venous disease due to reflux, obstruction, or both in deep veins, which is secondary to previous deep vein thrombosis, estimated to affect about 20 to 50% of those with deep vein thrombosis. So what are the signs and symptoms? Calf pain, this pain is prominent when the patient is standing, when the patient is walking, described as a bursting type of pain in the calf. Generally, the pain goes down with limb elevation. There can be limb swelling, there can be varicose veins. These are secondary varicose veins. And there can be skin changes, same as for complicated varicose veins, such as pigmentation, eczema, and ulcers. So, what are the risk factors for a patient with deep vein thrombosis developing post-thrombotic syndrome? There are several well-recognized risk factors: obesity, older age, more proximal DVT compared to distal DVT, recurrent episodes of DVT, and development of DVT in a patient with pre-existing superficial venous disease, smoking, residual symptoms after 1 month from diagnosis of the initial DVT event, and subtherapeutic anticoagulation. So how do you objectively assess the severity of a patient with post-thrombotic syndrome? There is a score which is named the Villalta score. And depending on the score, you can categorize the patient as having no PTS, mild PTS, moderate PTS, or severe PTS. If the patient has an ulcer, then the patient invariably falls into the severe PTS category. So let us look at how do you prevent a patient from developing post-thrombotic syndrome. The first thing we can do is preventing the index DVT event. For that, for high-risk patient, you have to prescribe thromboprophylaxis. It can be mechanical prophylaxis, it can be pharmacological prophylaxis, or it can be a combination of both. The patient should be suitable for the method that you prescribe, and depending on the risk of DVT, you can use an isolated method or a combination. And the role of compression garments after DVT, it has already been discussed. Again, some trials told there is a benefit, but the new trial, SOX trial, says there is no benefit. As the rule of thumb, if the patient is symptomatic, you can prescribe stockings. And the duration of stockings, previously it was told that to prevent PTS, it should be 2 years. The duration of stockings, as the rule of thumb, can be decided by the patient, him or herself. As long as it is comfortable for the patient to keep on wearing stockings, they can continue to wear. And thrombolysis for selected patients with ilofemoral DVT, again, reduces the PTS risk. For a patient with established post-thrombotic syndrome, how do you manage? Compression garments have a role, class 2 stockings, class 3 stockings. And if the patient is symptomatic despite stockings, you can prescribe pneumatic intermittent calf compression devices. So we don't have them available here in Sri Lanka, but in other countries, the Western countries, there are devices that the patient themselves can use at home. And there are Veno active drugs which claim to increase the venous tone. Again, very limited evidence. The one we have is the MPFF, micronized purified flavonoid fraction, or the brand name is Daflon. You have to remember, again, very limited evidence for these drugs. There is a definite place for exercise and lifestyle modification. The patient should maintain healthy weight, and the patient should be prescribed or should do calf muscle strengthening exercises for their calf pump to be more effective. And if the patient has a venous ulcer, the management principles are according to our previous lecture. And if there is concomitant superficial venous reflux, you can treat it in selective patients who do not have deep venous obstruction. Again, this was discussed previously. So what are the invasive strategies of management? The mainstay is endovascular management with deep vein recanalization and stenting. Again, this should be reserved for patients with moderate to severe PTS with lifestyle limiting symptoms. And the techniques are evolving and the evidence keeps expanding. So now there are the vein-specific self-expanding stents and the role of intravascular ultrasound to diagnose deep venous pathology and for using these deep venous stenting procedures. So in the other countries, the stent sizing and everything is done by intravascular ultrasound. Unfortunately, we don't have this technique available here in Sri Lanka, and we very rarely diagnose these deep venous pathologies because we lack the imaging, the facilities for easy accessibility to this imaging. Even CT venograms and MR venograms is very difficult for us to get a timely scan. And this is an image of a recanalized iliac segment. So you can see there is occlusion in the common femoral vein. common iliac vein. They have recanalized it, stented it, and now there is beautiful flow. So what's the role of open surgery in a patient with post-thrombotic syndrome? Again, very limited role. There are microsurgical techniques that can be used to reconstruct the damaged valves. And there are techniques for doing veno-venous bypass. But these bypasses have very poor long-term patencies, mainly because the venous system has a very low flow rate. So again, we have discussed this before. If a patient has combined superficial and deep venous disease, provided that you rule out deep venous obstruction, you can treat the superficial refluxing disease, provided the patient is symptomatic. So a lot of overlap. So that's it. Do you have any questions?
Yeah, so that brings us to the conclusion. So any questions from the audience? Anything at all on either superficial venous disease or deep vein disease? Last chance to ask questions before we ask questions in your exam. Sorry?
We are using the ultrasound scans, but as the first line investigations, this I have seen people tend to see the proximal extension of the DVT even after we have started treatment. So is it always necessary to see the proximal extent or?
Not at all. Not at all. There is no evidence to say that you need to, and there is no clinical justification for doing that. I know a lot of people, especially non-surgical colleagues, physicians, they keep scanning. I keep telling them, as I mentioned earlier, anticoagulation is to prevent clot propagation. Okay, anticoagulation, it prevents further clotting. It does not lyse your clot. I know a lot of physicians diagnose DVT, start warfarin, and after about 3 weeks or 4 weeks, do another scan to see whether the clot has gone. Not going to go like that, right? So it's pointless. And then they start new DVT and then start treating again. And then keep on doing it, keep on doing it. As long as the proximal clot is there or the first clot is there, they keep on doing scans and keep on continuing the warfarin. And sometimes just one episode of reversible risk factor, patients have been on warfarin for 2-3 years. Pointless. So the only instance I would say where you need repeated scans is if the patient develops further symptoms despite adequate anticoagulation. In a person who has previously had DVT, doing another scan and identifying whether it's a clot left over from the previous episode or new DVT is very difficult. You need to know then, you need to be a very experienced radiographer. There are ways and means of doing it. For example, I'll tell you now, for example, when you have a DVT, due to the thrombus and the inflammatory process, your vein becomes narrow. If any of you do scans, if you check artery and vein together, you will always know the vein is bigger than the artery. It's like a very sexist comment. It's like a thin husband and a fat wife, right? You see the artery is narrow and the vein is slightly bigger anywhere in the body, right? Popliteal, femoral, brachial, anywhere, right? But when you scan, if you see the vein either the same size or smaller than the artery, that's generally a post-phlebitic one, right? So that's due to previous DVT, due to the fibrotic process, just gets narrowed, right? So those are little tricks that you know you use to identify this is a new clot or an old clot. Other thing to do is to check D-dimer level, right? To see if let's say patient has a DVT 2 years ago, now there's a clot. You're not sure whether this is a leftover clot from 2 years or a new clot. So you do a D-dimer level. If the D-dimer is high, obviously you know it's very likely a new clot, right? But the answer to your question, checking the upper level, there is no indication unless the patient is having pulmonary embolism and you're considering an IVC filter, or there is iliofemoral DVT and you're considering catheter-directed thrombolysis, yes. Otherwise, for routine DVT management, no.
So another question, sir. If we have this, there in the guidelines, they are talking about treatment failures of the if a patient is already on warfarin and she's developing a new symptom, is there a indication for IVC filters? Or is it
When you say treatment failure or new symptoms, define the new symptom.
actually this was in a MCQ, sir, it was mentioned that she's developing symptoms of pulmonary embolism.
Yeah. So we discussed that earlier. No? When you're adequately anticoagulated, if you still continue to have pulmonary embolism, yes. So you need to have a very clear idea about IVC filters. IVC filters are for patients who cannot be anticoagulated, right? Active hemorrhagic stroke, malignancy awaiting surgery, that kind of already existing thrombophilia or existing thrombocytopenia or bleeding risk, yes, then you can't anticoagulate. No, they need IVC filter. Polytrauma patients, they need IVC filters. But if you don't have any of those contraindications, then you don't need IVC filter. Only other exception, like in your question, is if you have started therapeutic anticoagulation, okay, you have started warfarin. She's taking warfarin. INR is also therapeutic range, 2.5. Despite that, they get recurrent evidence of pulmonary embolism. Then yes, no question, you need a filter, ideally. Yeah.
Keep it.
Sorry?
Applying 4-layer bandage, how long we have to keep it?
This is for venous ulcer.
Yes,
Venous ulcer.
yes.
So there is no rule to say you have to keep it for 3 days or 4 days or 1 week or whatever. The idea is to continue strapping until the ulcer heals. How frequently you keep the bandage or keep the 4-layer strapping depends on a lot of things. Number one, the size of the ulcer and the degree of exudate. Some ulcers are small and they don't have a lot of exudate. So that kind of patients, you can use 4-layer ulcer and you can 4-layer strapping and ask them to come in 1 week. Some patients, I even ask them to come in 2 weeks' time if they're coming from Jaffna to Colombo just to see me. Okay. There are other big ulcers which are so much exudate. You put the strapping, by tomorrow it's leaking out, right? So then you have to do it more frequently, right? So there is no general rule to say 4-layer strapping has to be changed every 3rd day or every 4th day. It depends on the degree of the ulcer, the degree of exudate, size of the ulcer, and so on. And depending on that, if it's a heavily exudating ulcer, 3-4 days time it comes out leaking, then you need to do it more frequently. If it's a small ulcer dry, then you can keep it even 1 to 2 weeks.
So what is the difference between dead stopping and compression hosiery wearing for varicose veins?
So, Tilina, would you like to answer? Dead stockings and compression stockings. So there are class 1, class 2, class 3, class 4 stockings based on the pressures. Yeah.
For ulcer, I think you have to use a class 3 for ulcers and lymphedema class 3. So all these classes depend on the ankle pressure you get by applying the stockings.
If you check one of the commercially available stocking packets, those pressures are mentioned in the back. Okay, class 1, class 2, class 3, class 4. So class 1 stockings, as Tirina said, those are the TED stockings. Those are more for prevention. So patients going in for some major surgery, you want to prevent, yes, class 1 stocking, the white color, simple stocking. Class 2 is generally given for patients with varicose veins where you want symptomatic relief until a definitive endovenous ablation or something is done. Patients with active DVT, ulcers, you generally recommend either class 3 or class 4. Class 3 and 4 are generally above 30 millimeters mercury pressure at the ankle. So it all depends on the degree of pressure that you need.
Thank you, sir.
Yeah, yeah. So that's very simple, no? Goes back to your workshop triad, no? DVT, what are the risk factors for DVT? Obviously, anything that promotes clotting. So polycythemia is one. Dehydration, polycythemia, malignancy, immobilization, congenital thrombophilias, the list goes on. Any other questions? Okay, so we'll conclude then. Let me, on behalf of the college, thank all of you for coming on a Saturday morning and all the panelists for contributing. If there are any more questions, you can even direct it through the college to us, or on a personal basis, even you can let us know. I mean, most of you all are trainees and you come across, we come across each other, so you can ask us anytime. Huh? So there's one question from Pera Diniya. In a patient with DVT, when to do repeat scans? If the vein is not recanalized, what is the management? So we touched on this earlier. As I said, there is no indication to do a repeat scan unless the patient has ongoing symptoms, right? So now let's say I diagnose a DVT today. I put the patient on stockings. I started them on rivaroxaban or warfarin, adequately anticoagulated. They are compliant, all that is good. But patient comes and says pain is increasing, swelling is increasing, something is going on. Then yes, I would like to see whether there's an extension, earlier femoropopliteal, now going up to iliac. So then I know obviously my anticoagulation is not working. Then I need to consider that this patient may be having a resistance to anticoagulation and think about some other method of treatment like an IVC filter. So that kind of patients, yes, if despite your treatment, if the symptoms are progressively worsening, yes, then you can do a repeat scan. And the second part of this question is, if the vein is not recanalized, what is the management? Then nothing, because the recanalization of the vein, remember, I'll tell that and please feel free to join in. So, as I said earlier, this is very, very important to get this very simple idea in your head. Okay, DVT, clot inside the vein. Anticoagulation will prevent further clots. The original clot that happened in the vein, warfarin and heparin hardly has an effect on that. Okay. If you want to get rid of that clot, you need thrombolytics. That is urokinase, TPA, alteplase, tenecteplase, all that. They are costly, has a lot of side effects, and not everyone can tolerate it. That's why you don't do it routinely in any country. Not routinely. Selected patients, yes. However, the funny thing about this original clot is your body has a natural thrombolytic mechanism that will invariably get rid of this clot with time. How much time it takes, no one knows. It sometimes takes years. 1 year, 2 years, 3 years, several years it might take. But that is okay. As long as you have prevented the anticoagulation, you have given the anticoagulation for 3 months or 6 months, the designated period, your idea here is to prevent propagation and prevent pulmonary embolism, not to lyse this clot and recanalize this. Recanalization will take its own time and happen eventually. There's no point in repeating scans and seeing whether this is recanalized or not recanalized. Then let's start warfarin again. There's no point. There is no indication for that. Okay. But just touching on the last talk of Tirinas about post-phlebitic limb, how you get post-phlebitic limb is also because of this. Because during this natural thrombolytic process that the body does, the body can't differentiate between the clot and the valves. So the natural thrombolytic process, when it happens, it will dissolve the clot and it will also destroy the valve. So that's how you get a refluxing deep vein, ending up with post-phlebitic limb. So the other side of the argument is then you do immediate catheter-directed thrombolysis. Before the clot gets organized, within the first 2 weeks, if you get a patient, you place a catheter, give an infusion of alteplase or tenecteplase, dissolve the clot, you remove the clot burden from the body, and you also preserve the valves, theoretically preventing post-hepatic syndrome. So that's the idea behind it. Did you understand that?
So what is the principle of managing DVT causing acute limb ischemia?
DVT causing?
Acute limb ischemia.
Extremely rare. Phlegmasia severely adolescence. Yeah, so you need to do thrombectomy. You need to do venous thrombectomy and or thrombolysis, but very poor response, very poor prognosis.
Excuse me. So in the truncal varicose veins, in the C2 and C3 lesions, what we are usually recommending for this non-surgical management of
Sorry, sir, truncal veins?
truncal varicose vein, that great saphenous or less saphenous for the C2 and C3 lesions.
Yeah.
But if you are talk about this cost effective for, if you are going for this stockings management, usually the expensive of stockings will be a bit high. And usually what they are recommending is changing the stocks for every 2 to 3 months. At the same time, the quality of life also will be get something who are very high professional people. So if you are arguing with these kind of argument, if can we offer the patient for surgical management for those patients?
C2, 3C lesions.
Yes.
So C2, C3, varicose veins with truncal reflux, right? So if the truncal reflux is causing, as you said, symptomatic discomfort, then that's an indication to treat.
If you are recommending for compressive management for stocking management.
Yeah, so why would you recommend compression stockings if the patient is symptomatic and in discomfort?
Yes.
No, it's it just be very clear. Regardless of the stage of the veins, right? C0 to C6 is a classification that we use. Symptoms from varicose veins is a subjective thing. If the patient comes and says, I only have one spider vein, but I have pain over that area, or I think it's ugly, that's subjective. You have to treat that. Okay. Is that what you asked? Is that the question?
If the patient asks for any kind of management.
Yes, so you have to specifically say, so if that patient came to me and asked me, I would say several things. One, okay, you have C2, C3, whatever, you don't have ulcers, you have varicose veins, refluxing veins, okay? You're only going to get older with time. You are not getting any younger, which means your varicose veins is never going to get lesser, okay? So I'm going to ask, are you willing to wear stockings for the rest of your life? If you get if this C2, C3 gradually progresses and becomes C4, C5 when you're 75, 80, are you willing to have the treatment at that time? Very simple. Okay. So you need to, unless the patient is vehemently against treatment, yes, you can put on a stocking. But you need to make them understand, but by putting a stocking, you're not going to reverse the refluxing disease. Okay. Right? It's like you wearing specs. Just because you wear specs, your eyes internally don't get better. No? As long as you're wearing, you're fine. You remove it, you can't see again. Same thing. No? So unless you're ready to wear your stockings for the rest of your life, okay? Understanding that with aging, anyway, this is going to get worse. Then there is no indication to put on stockings long term. Generally, I would never recommend stockings long term. You just have to have a frank idea and understand. Most of the time, patients will be scared of surgery or scared of things thinking surgery. They have very funny things about varicose in lay population. They will think karate passe that you can't walk. The leg will get short after varicose vein surgery. These are things that people sometimes come and say. Okay. You need to have a discussion and ask, why are you worried? You ask them now, if they come and ask me, they don't want to get surgery done, they're scared. I ask, what are you scared of? Are you scared of not being able to walk? I will say, I'll do the laser and make you walk within 5 minutes. Are you scared of pain? I'll tell you, I will make sure that you don't have any pain. Even if you have pain, that is for the first day after treatment. Here with varicose, you'll have pain for the rest of your life. So what would you trade? 5 minutes of pain or 10 minutes of pain versus pain for the rest of your life? It's a very open discussion. You need to have a clear idea what you're treating. Okay. So stockings have a very limited place in varicose. Okay. I would recommend stockings only for pregnant women. Other than that, I won't recommend stockings as a measure of treating varicose. Any other questions? Good essay question. Management of comprehensive management of superficial venous disease. Okay, so we'll conclude then. Thanks.